A very good afternoon to all of you. It's my pleasure and to welcome all of you for this very interesting quest series 2. And in this series, we are going to today tackle PPH. And we all know that PPH is one of the fastest killers. And so it's very important that we keep our time intact. So I think I wouldn't say, without saying much, I would move on to we'll move ahead with the program. And I would like to thank Shanta Kumari and our Secretary General Madhuri Patel for giving us this opportunity to convene this session, which is very, very important in our day-to-day practice. So to start the program, I now invite Dr. Kiranmai Devneni to start the first session. And we all know Dr. Kiran very well. Can I have the first slide of Dr. Kiran? Yeah. She is now, there was one word I would like to add to her already. Her long list of achievements is that now she's a professor in OBGYN at Vanaparthi, belonging to the Kaloji University of Health Sciences, Telangana. And of course, she is.
Thank you, ma'am.
So I think that's
yeah.
Rest in the
I think, yes, ma'am. Thank you, and I extend my gratitude to, and it's a great privilege for us to be part of this. And thanks to Shanta Madam, our President, Madhuri Madam, the entire team of FOGSI, and we have a very dynamic Vice President with us for this quest too. That is our Archana Verma Madam, who has been there throughout, and she'll be taking a major part of deliberations today. She'll be moderating a panel also. So thank you. So without further delay, because our time starts now and PPH, we can't waste time. We'll go quickly with the fast track to tackle PPH. In this, we have 6 topics, 10 minutes each. And from AMTSL, that is prevention, then the mnemonic of hemostasis, we have put it to cover the entire gamut of management of PPH. So the first topic is AMTSL. From protocol to practice, where are we? For this, we have invited Dr. Preeti Kumar, the committee chairperson of Safe Motherhood Committee, who has been doing a lot of on-field work in Jeevan Dhara and so many other projects with lot of international and national engagement. But because she could not be with us today, on her behalf, we have Dr. Nivedita Datta, who is the East Zone Coordinator for the Safe Motherhood Committee. Can we have Dr. Nivedita's? Please. I want to chair this session. We have Dr. Manila Kaushal. Can I have Dr. Manila Kaushal's CV? Madam is President of Indore OB-GYN Society and also Associate Professor of Department of OB-GYN in MGM Medical College, Indore. And I was so impressed with the list of awards that she has. You name it, she has it, right from SS Ratnam, Korean, Kamini Laureate, International Fellowship Award, and so many other things. Without further delay, I'll invite Dr. Manila Jain Kaushal to introduce our first speaker and the topic, Dr. Nivedita Datta. Manila, ma'am.
Thank you, madam, for such a wonderful introduction. And thank you, Kiranmai, madam, for giving me this platform to share my thoughts with every one of you. And without wasting much of time, can I have CV of Dr. Nivedita? So for the first talk, we have a very interesting topic, active management of third stage of labor from protocol to practice. Where we have a very dynamic speaker, Dr. Nivedita Datta from Bokaro. And she is a coordinator of Manyata Champion in Jharkhand. And she's doing palliative care. And her area of interest is high risk obstetrics, infertility, vaginal surgery. She's an active member of Safe Motherhood Committee. That's what I can see her. And also of ISOPA, Food and Drug Committee, Oncology Committee, and such a very, enthusiastic person I could ever see her. So over to you, Dr. Nivedita. Let's have an interesting talk from your side. Dr.
Dr. Nivedita, you are muted. You are muted. Unmute yourself.
Sorry. Yeah. Thanks a lot, Dr. Manisha. And at the very outset, I would like to thank the organizing committee for giving us this honor. Respected President Ma'am, Dr. Shanta Kumari, past presidents of FOGSI who are here, gathered here today, the President-elect, Vice Presidents of FOGSI, then the Secretary General, Dr. Madhuri Patel, and all the FOGSI office bearers, dignitaries, as well as delegates gathered here today, for giving us this opportunity to present before you all a brief glimpse of Project Jeevandhara, a project which was done on PPH by Safe Motherhood Committee under the leadership of its chairperson, Dr. Preeti Kumar. She would have been here to present this talk, but unfortunately she's traveling, so I'm presenting this talk on her behalf. It gives me immense pleasure to be sharing a brief part of this project, and this part is mainly on the preventive aspect, that is AMTSL. We have done in-depth surveys of this, and this is where I'm presenting the data from protocols to practice. Where are we? We all know that AMTSL is a prophylactic, deliberate, and effective intervention to ensure smooth expulsion of the placenta for prevention of PPH. PPH accounts for a major cause of maternal mortality, and hence FOGSI now recommends universal AMTSL. After much deliberation, the government of India has said that active management of labor is divided into three major components. The first is administration of a uterotonic, obviously after excluding a second twin. Second is controlled cord traction once the uterus is contracted. And third is uterine massage to continue to keep the uterus contracted. Active management of third stage of labor, the most important component is the administration of a uterotonic. There's a major knowledge gap in this aspect amongst even clinicians. In spite of the huge number of oxytocics or uterotonics in our armamentarium, the government of India, FOGSI, as well as WHO, has only accepted oxytocin as the drug of choice for active management of third stage of labor. And the route of administration was intramuscular, 10 international units. There again is a big practice gap amongst a lot of clinicians. FOGSI has accepted an intravenous route, but the dose is only 5 units, that is 1 ampule, and it has to be diluted to 5 ml and has to be given over 1 minute. This is very important because a lot of people are giving it intravenous without knowing the actual dose and how much and how long the duration of the intravenous infusion should be. Bolus doses are inappropriate in women with cardiovascular diseases and hence not recommended. A major drawback with oxytocin has been its storage, because we all know it has to be maintained at 2 to 8 degrees C in the door of the refrigerator. In countries with cool climatic conditions less than 25 degrees, it can even be kept at room temperature for 3 months. And this definitely is not valid in the Indian subcontinent. We can't maintain this temperature weather-wise. So a major challenge for oxytocin is to maintain the cold chain from production to transportation to storage, as well as administration. So the new kid in the block is Carbetocin. 100 micrograms, again intramuscular. Advantage is a longer half-life and definitely the room temperature stability. All studies in prevention of PPH have been shown it is non-inferior to oxytocin. However, the cost factor remains a challenge. WHO does not, and here does not recommend for AMTSL injection methyl ergometrin or injection prostaglandin F2 alpha. Why? Because one, safer option is available, and two, these two also require storage at 2 to 8 degrees centigrade. The second important aspect of AMTSL, where we have seen a huge practice gap, is controlled cord traction by skilled birth attendant. And the practice gaps have been where to clamp the cord close to the perineum, the signs of placental separation, the direction of traction, and the method of traction. Although not a part of AMTSL, but here let me just point out that exploration of the uterus is not recommended anywhere, and yet it is being practiced by most of the healthcare workers surveyed. Jeevan Dhara was a virtual training in the management of PPH. The first stage, phase 1, was done in 3 states, Uttar Pradesh, Jharkhand, and Bihar. And it was a 6-month-long project. It was not just a webinar. 11 districts enrolled, 40 private facilities, and 4 medical college hospitals, which were the referring hospitals for these 40 private facilities. 100 doctors and 250 healthcare workers were surveyed, both pre-training as well as post-training. And this is what I would like to mainly share. If you can see, there is a huge gap in the uterotonic of choice. A lot of people supported methergin or methyl ergometrin as a uterotonic of choice. Even those who supported oxytocin, the route of administration, IM/intravenous, was a big gap. The most important component of AMTSL, a lot of people still think control cord traction, a few people still think that control cord traction is the most important component. But the point where most of agreed and had no knowledge gap was on storage of oxytocin. That is, most of the doctors knew that it has to be stored at 2 to 8 degrees centigrade. But what is very strange is that although the knowledge was there in a lot of doctors, if you see this thing of healthcare workers, 17% of the healthcare workers did not know that oxytocin had to be stored in the fridge. That means there is a difference between what we know and what we practice. And hence, our healthcare workers practice what we practice and not what we know. Now, there was a big gap in the knowledge of the components of AMTSL because most of the healthcare workers in these three states did not have any formal education in nursing. And hence, they were not very confident about the components. But if you can see, the end line survey is spectacular. We had a fantastic result post-training. And because of this huge success of Jeevan Dhara phase 1, UNICEF approached Safe Motherhood Committee to do the same project in 3 aspirational districts of Uttar Pradesh in the public sector facilities. The 3 districts were selected, 8 facilities were enrolled, and here are the studies of the 8 facilities enrolled. This is the survey for the healthcare workers. The knowledge of the healthcare workers is so far as storage as well as the components is really good. And that is probably because of the rigorous nurse mentoring, which is done by a lot of international organizations like UNICEF, JAPIGO, etc. But they had where it failed was their knowledge that AMTSL is actually preventive for PPH. But now, surprisingly, you see the survey for the doctors, it is dismal. In one facility, the doctor did not even know the components of AMTSL. Somewhere the doctors had no idea that AMTSL was preventive for PPH. In fact, that PPH could be prevented at all. And the reason is probably because in the public sector, a lot of stress is given on the mentoring of the nurses. With the government not shifting the nurses from the labor room to the other areas, the nurses have got much better knowledge than even the doctors on duty. This is a very sad state of affairs. Now, you can see that most of them have a good knowledge that oxytocin has to be stored at 2 to 8 degrees centigrade. However, what we found on-site visit is that the labor room does not have a fridge, and oxytocin is actually stored in the shelf in the pharmacy. So, the lessons which we have learned from Jeevan Dhara 1 and 2 is that we have to improve awareness among the providers on standardized evidence-based protocols, as well as maintaining the cold chain, that is awareness not only among doctors and nurses, but also among the chemists and the pharmacists. We have to ensure implementation of protocols by skill upgradation as well as by regular drills. And we should ensure resource availability. So there has to be a tie-up with the government in every place. Then we should document and audit the improved outcomes if we want these kind of things to be sustainable and accepted by all the obstetric care providers. Ladies and gentlemen, a skilled healthcare worker can lead to a 54% reduction in mortality at birth. I request all of us to join hands to ensure that we have a good team of skilled providers so that maternal mortality can be brought down to a single-digit number in India. Thank you.
Thank you, Dr. Nivedita. That was so prompt on the dot for 10 minutes. And Dr. Manila, I will have a quick comment, one comment from you so that we will move on to the next talk. Thank you so much.
We were really amazed to see the success of this Jeevan Dhara project and the inputs which was done by the Safe Motherhood Committee for the same. And we really believe that this active management of third stage of labor is a very important aspect of PPH prevention, and the wonderful work which is going on should go ahead, and best wishes for the same. Over to you, Kiranmai ma'am. Thank you. Thank you for involving.
Thank you. Thank you.
Thank you, Dr. Nivedita. Can I have quickly Dr. Anjana Khanna, Madam CV? Madam is going to chair the next talk. Madam, we all know there is no need to introduce. Madam has been National Vice President of FOGSI 2017 and ICOG Governing Council, President of Allahabad Society, and she's a faculty at various national international conferences with lot of awards, FOGSI Smriti Mailan and Dr. D.K. Tank Reproductive Healthcare Promotion Trophy, and many felicitations. And Madam is a very sweet person. Always been happy to interact with you, ma'am. Welcome you to introduce our next speaker, none other than Dr. Mitra Saxena. Can we have Dr. Mitra, Madam CV, please, quickly? Ma'am, we are not able to hear you, Ranjana, ma'am. Not audible. Volume, just check your volume, ma'am, once. Venkat, can you unmute Dr. Anjana, madam?
One second.
Yeah, what is happening? Madam is not able to speak. Just check.
But ma'am is unmuted.
Ma'am is unmute only.
Unmute only.
Maybe in her laptop the sound
The speaker is not functioning.
Let her speaker be checked. Maybe there the volume is low.
Not able to hear. You are unmuted, ma'am. You are unmuted.
Please check your sound level.
No, ma'am, we still can't hear you. Ma'am, could you log in with your mobile? Otherwise, I think there's something wrong with the speaker of your laptop, ma'am.
Actually, mobile was giving trouble, so she joined the laptop. I sent her to.
Now is it all right?
Yes, ma'am.
Ma'am, yes, ma'am.
Can you project the slide once again?
I'll mute this then.
Ma'am, log out from the laptop, ma'am.
Pardon?
Log out from the laptop. Log out from the laptop.
Okay. Yeah, I've logged out now.
Yes, ma'am.
So now it's all right.
Yes, ma'am.
A very good afternoon, everyone. And thank you, Kiranmai, for the invite. PPH, we all know, is such a deadly condition that the moment it starts, of course, Dr. Mitra is going to tell us how we have to shout for help. And the 4 T's about the etiology, I think everyone is familiar. It's stone, tissue, trauma, and thrombin. So I would like to invite our dynamic speaker, Dr. Mitra Saxena. She is chairperson-elect of Practical Obstetrics Committee 2021 to 2023, senior consultant obstetrician and director, Shri Ashwini Saxena Hospital, Rewari, and past president and now patron of Rewari Obs and Gynae Society. She is a national faculty with areas of interest in high-risk obstetrics. And Dr. Mitra Saxena, we would love you to please give your talk.
So, I'm not able to make it full screen.
It's,
Why?
but we are able to see it, ma'am, clearly.
Wait, I'll just, I'll share it again, Kiran.
Yes, ma'am.
Just give me 1 second. Actually, I had left it open.
These are all, glitches.
Sorry, these are
No,
technical hazards.
Help sometimes we can't.
Yeah. I checked it and I opened it, and then now I'm finding I shouldn't have done that maybe. So again, it's not becoming full screen. Okay, now.
Yeah, it's done.
So my time will start now. A very good afternoon to everybody. And I'm the first batsman in this fast track sixer to tackle PPH, H and E. So thank you, Kiran Mai, for having me on board. This is the mnemonic which Kiran Mai has selected. I've been asked to speak on H and E, and I have taken the liberty to just spread it out a little bit because every single alphabet is very important. H standing for help and hands, A for and assess and resuscitate, E for etiology and acknowledge. This is one condition all of us obstetricians know. When all our modalities, all the 5 senses, all the muscles, everything has to be enabled so that we can tackle this big killer. And from where Dr. Nivedita left in AMTSL, that there are uterus has to be massaged, I think this is the stance of the person who's conducting the delivery. The details will be elaborated by my next speaker on uterine massage, but this I'm sure everybody understands. Even the nurse midwife or anybody who's doing it, this is the hands have to be on the bimanually, so the uterus is compressed. So the first H is shouting for help. We all know that this is an emergency which cannot be managed by one's own self. And H stands not just for help, shouting for help, so that a whole team, a multidisciplinary team, if the hemorrhage is excessive, even otherwise, those people who know what is to be done, the trained nurse, a resident, a senior obstetrician, OT may be informed, anesthetist, hematologist, transfusion expert, depending upon where have we got this patient, and we need hand to assess the vitals, to put hand on the uterus and proceed to carry out small orders, to take the samples from the labor room to the blood bank, and so many reasons. So H is very, very important, and hands to document everything at the end of the procedure. Now, in A, this is very, very important that the assessment of the patient has to be done on terms of the pulse, blood pressure, respiratory rate, temperature. Clinically, even if we don't have blood counts, just a look at the conjunctiva and we know it was an anemic patient. We don't have to wait for her to bleed 1 liter to say that she's in major PPH. Our clinical assessment, urine output, and everybody must have this alertness about shock index, that both approaching 100 is okay, but heart rate going above 100 and blood pressure falling below 100 is again difficult. Now, before we go into quickly recapitulating the resuscitation, it's important to remember the color coding of the cannulas, and every laboring patient, we make sure that the number of cannula we use prophylactically is green, 18 gauge. So where 80 mm of 1 second. So with green cannula, the amount of fluid that can be rushed in is 80 ml per minute. But when we are having PPH, the gauge is gray, 16 or orange. We can see that the amount of fluid that is pushed in a minute is 150 and 300. So when we are trying to save a patient who's bleeding torrentially, this is very important to remember that what are we going to, what cannula we should put. And this cannula should be available in the labor room. So after assessing the general condition of patient and putting another cannula with those hands, drawing at least 20 ml of blood for sending for complete blood count, grouping, cross-matching, because a patient who's rapidly losing blood may need blood transfusion, and also send investigation for coagulation profile. Because this is a quick recap of what are the fluids that are to be given. We can tide over the emergency time with at least 3.5 liters of warm fluid, initially with normal saline crystalloids and then colloids. But if patient is continuing to bleed, it's a major PPH, then we already have to order blood and its component. I'm not going to go into the details of all this, but what is important is volume replacement and ensuring that the oxygen carrying capacity has to be maintained. So irrespective of the SpO2, at least 10 to 15 liters of oxygen should be administered to the patient. Now, this is, of course, we need detailed discussion, but all of us are quite aware that volume of blood loss has to be replaced by blood and its components. So we have PRBC, we have the FFPs, we have the cryoprecipitates and the platelets. So every part is extremely important whenever there is major PP. Mantra for safe obstetrics is anticipate, prevent and manage. So AMTSL has been covered to anticipate and manage and prevent the hemorrhage. But when we are managing PPH, our mind has to really go on to the etiology. And friends, every seasoned obstetrician is very much aware. Our hands are in the bimanual compression, so we know what is the tone of the uterus, whether it is the atony or there is some trauma or there is some when the placenta has been delivered, if there is any lobe or any part which is missing or the membranes have just dropped down and we expect some membranes are to be there, or the blood is not coagulating, the blood is falling in the bucket and there are no clots formed. These are clinical, giveaways that we know what could be the etiology which is landing us in trouble. This is a quick recap of all the possible reasons. Whenever a patient is anemic, over-distended uterus, anemic, grand multipara, with a lot of and in prolonged labor, or she has been augmented in labor, we have to anticipate, we have to be prepared for the atonic element of PPH. Sometimes the patient is so anemic that we cannot actually wait for 500 ml that she will go into hemodynamic instability. So all the time our alertness in what kind of patient we are dealing. When the uterus is well contracted and still there is fresh bleeding, all of us are aware that it is the traumatic bleeding. It will be very prudent to remember that before we start stitching in episiotomy and after making sure that the uterus is well contracted, we should inspect all the possible areas where there could be some laceration. If it has been prolonged labor or quick delivery, we should rule out cervical tears and vaginal tears, because once we start stitching the episiotomy and then we land up with this traumatic PPH, we are actually put ourselves in trouble. Again, in cesarean sections or where there is adherent placenta, there will be trauma to the uterus, cervix, lower segment and cause PPH. Again, whenever there is a substantiate lobe or a part of placenta is missing, so if delivery has been conducted very carefully and the placenta has been examined, every protocol, that means no need to hurry, no need to be absent-minded, always look at the placenta, make sure that the placenta and membranes come out completely. We will not be worried because of this reason for PPH. Again, thrombin. Whenever we have a patient with accidental hemorrhage, PIH, there is an element of abruption. We know these are the patients who have coagulopathy and they are more likely to go into PPH. So this is a quick recap for etiology, which while we are managing the patient, simultaneously assessing, resuscitating, and also thinking about the etiology. The other E is ensuring blood and ensuring ecbolics. Ecbolics are those medicines which make the uterus contract. So Dr. Jayam will be taking it in detail. But it is very important for us to remember all these medicines which are there available in our armamentarium. And of course, as Dr. Nivedita has already specified, that how oxytocin is important. If you are practicing AMTSL, majority, more than 50% of times, we do not have atonic PPH. And these ergot alkaloids, carbetocin, carbaprost, mesoprost, they are all second line drugs. Of course, carbetocin now, with its advantage of being heat stable, this has been a very good tool in our hand, and wherever we are expecting. So my take home message would be, in those patients like the first category where we are expecting atony, we can actually shift over to start giving carbetocin instead of just oxytocin, and see in our patients how it works up. And I've started doing that. Now, we all know that carbaprost, these are methogen or ergot alkaloids. They have to be used with caution depending upon the patient setup. You cannot use in hypertension. You cannot use carbaprost in patients with pulmonary or cardiac problems. So with all that drugs available for us, I think we can manage the medical part. And over to you, Dr. Kiran. I hope I finished in time. My first two, spread out 3 mnemonics. Other mnemonics.
Thank you, ma'am. Thank you so much, Mitra ma'am. Ranjana ma'am, your comment.
Ma'am, please unmute.
Unmute, ma'am. Ma'am, please unmute.
Yeah, that was a lovely talk, Dr. Mitra. And I do believe that 70% of the cases of PPH are because of tone, loss of tone. And you are very right in saying that carbetocin is definitely a better drug than the others. But I prefer to give it slow intravenously after the delivery of the baby. It's given in 1 minute and it has got a wonderful response. And furthermore, I would like to say that what is very important is that if the uterus is very well contracted after a normal delivery and the patient continues to bleed, what is most important is to look out for vaginal and cervical tears. Because cervical tears, if they are very small, they can, and they are not bleeding much, we can leave them be. But sometimes they can bleed profusely. Then we have to examine it after exposure and all. And similarly, the vaginal tears. So what is important is that we have to be multifaceted at that time. And we have to make sure that the uterus is well contracted, keep on a gentle massage, bimanual compression. And if she's bleeding profusely, then even we can give aortic compression. So that would also help. And that was wonderful. And I think by this time, we all are now big experts, though we never want to see PPH. That is my stand.
Thank you, ma'am.
Thank you, Dr. Ranjana, for the value addition. Thank you.
Thank you, Ranjana ma'am. Thank you, Mitra madam. For the next talk, that is massage and oxytocin, we have our chairperson, Dr. Manisha Maheshwari. Madam is a senior honorary consultant at Divisional Railway Hospital, Ratlam, and she's also the president of Ratlam OB-GYN Society. Welcome you, ma'am. I'll request you to introduce none other than Dr. Jayam Kannan, ma'am.
Thank you, madam, for having me here in this quest series of tackling PPH. And Madam Dr. Jayam is a senior member of FOGSI. Can I have her CV, please? Yeah. She's emeritus professor in Tamil Nadu MGR Medical University, and she has major achievements like President of India Medal for Outstanding Performance in MBBS, State First in MBBS, and Lifetime Achievement Awards of IMA, Tamil Nadu MGR Medical University, Trichy Women Association. She has many awards and RCOG award, which is for Distinguished Service Medal 2018, first Indian to receive. And I invite Madam Jayam to speak on the two important components of active management of labor, that is uterine massage and role of oxytocin. Madam, the floor is yours.
Thank you very much, Professor Manisha Maheshwari, for introducing me excellently. The topic given to me today is uterine massage and oxytocin. The PPH has been already stated by my previous speakers as prompt recognition, resuscitation, and arrest of bleeding. But most of the time, the bleeding cause becomes a bizarre one, not to be identified before it is referred to a higher center. But one word I would like to say is it is not golden hour or anything. It is golden seconds, then maybe minutes which we lose in our work. As already said, atonic PPH has been very dominantly the cause of it. And the highlights of this is in every case of delivery, we should expect this. And the routine use of AMTSL becomes a critical procedure. Congress 2013 came out with Hafmeyer, who is an authority in obstetric, practical obstetric work. And he talked about uterine massage after delivery. The placenta can promote contraction of the uterus. Place a hand on the woman's lower abdomen and stimulate the uterus by repetitive massaging or squeezing movements. Give every 10 minutes for 60 minutes after the delivery of the placenta. It reduces the blood loss and need for any or further oxytocin in 80% of the cases. However, sorry to say, there is no trial of isolated uterine massage in settings where even uterotonics are not available. There are no data available. There is disadvantage of the uterine massage, includes the timing of the staff which is spent with the patient and discomfort caused to the patient. And after 8 years, 2021 reasserts the need of uterine massage, and it has shown that it has a statistical significance between the groups of not using the massage and using the massage by the estimation of the hematocrit values, pre-delivery and pre-discharge values of 24 hours. And it has shown that the transabdominal uterine compression in the form of bimanual, iodic, and other compressions are equivalent to uterine massage. Both are equally effective, showing the superiority of the uterine massage by American Journal of Perinatology and Healthcare Women just about 6 months ago. WHO has recently come out with a nice orange color book on postpartum hemorrhage, and in which it talks about the Cochrane review, which involves 1,55,000 plus women, and it involves nearly 196 trials, which compares the uterotonic options with no uterotonic and combination of uterotonics also. Now comes to what are oxytocics, what is oxytocin? Oxytocics are pituitary analogs, ergot alkaloids, and prostaglandin analogs. The pituitary analogs are oxytocin and carbetocin. Ergot group becomes the ergometrin and methyl ergometrin, and prostaglandin analogs becomes PGU2, misoprostol, and carboprost. What is oxytocin? It is an octopeptide synthesized in the hypothalamus and stored in the pituitary, and is available in the trade name of pitocin, syntocin, etc. All of them have 1 ampoule of 1 ml equal to 5 units, or 2 ampoules of 2 ml equal to 10 units. That's a very, very standardized one which has been given internationally. The half-life is less than 10 minutes. The duration of action is less than 20 minutes. So if you need to keep the uterus contracted in a tonic PPH, need to give IV continuously for about 6 to 8 hours minimum. It is also given for induction of labor, in which case the oxytocin pre-delivery desensitizes the oxytocin receptors and impair its function post-delivery. That is, so in majority of the induction of labor cases, oxytocin alone may not be able to control the postpartum hemorrhage. And there is no dosage consistency in any of the trials which have been talked. And IV oxytocin, kindly note, is kept in the high alert list of drugs by the Association of Drugs regimen. And settings where multiple uterotonics are available, like a secondary care setting or tertiary care setting, what to give, what not to give, whether I should give for vaginal birth or cesarean. It all depends on the skilled personnel who are available. It can be a combination of misoprostol and oxytocin, or oxytocin with even any other drugs also. Settings where oxytocin is not available. It looks surprising for anybody to think that I have a labor ward without oxytocin, or I have a labor ward without a refrigerator where my oxytocin quality cannot be guaranteed. Here comes the use of other injectable like the prostaglandin group or the ergometrin group. And even here, whatever oxytocin is available, whether it is filled or not filled, can be given along with ergometrin and misoprostol also, which is being recommended by the WHO recent 2021. Now coming to the skilled birth assistants not present. First one is oxytocin not available, but now there is no skilled doctor like a DGO or MD or anybody, or a traditional birth attendant who is well trained. Now there is a DAI or somebody lay. What they can do? They can put the oral misoprostol or per rectum misoprostol 400 or 600 microgram. Even by a lay health worker, it is preferred. Now, we have 2022, a week ago, 19th of this month, a book released called Why Mothers Die book. This thing, a decade of analysis of maternal death, 1,500 plus deaths, in which 1,056 deaths have been, every case has been analyzed. And it says that 16.8% is the cause of obstetric hemorrhage caused the death. And here, it has been very clearly noted. Unfortunately, AMTSL has not been very clearly practiced in all these cases. And this suggestion from our own Indian book, one week ago, should take us to the lead. And now take the 21-year-old prima gravida. She comes 4 days before the term date, 39 weeks and 4 days, induced with prostaglandin at 9 a.m. Within about 6 to 7 hours, she delivers by a vacuum, and AMTSL is done. Within 15 minutes, she develops postpartum hemorrhage, all the tampons, everything applied, her blood pressure shoots up to 150, 110, labetalol is given, 1 pint of blood is also given. Her pulse goes up and BP becomes not recordable. Get referred to the higher center, and where emergency obstetric hysterectomy was done. She was put on ventilator. After all trials and this thing, she had died after 15 days. In this case, where all we failed is the question which takes us to the use of oxytocin. First one is, what is the need for induction with oxytocin when she has got another 3 days more without any complication? That's the first thing. Because this thing has become sensitizing. The clinical estimation of blood loss is usually not correct with any of our clinicians, and there is a need for this thing. And we always think more of amniotic fluid is mixed with the blood, so the blood loss is not too much. That's the second thing we think. The third one is the patient developed 150, 110 blood pressure, which was mainly because of the oxytocin minus adequate fluid volume replacement, which Mitra was time and again stressed, and all these events, which were done in the few seconds and minutes, has led on to the failure of whatever energetic care that this patient was being put on. So now our new thoughts are getting on to the paradigm shift of, in all cases of management, with every case of delivery with preparedness, prevention, diagnosis, and immediate response, and keep a PPH box, which includes the oxytocin drugs and the instruments. Next comes this carbetocin, which in the last 1 year, everybody's ear has been deafened by carbetocin. 100 microgram IV, it's an oxytocin, uterotonic, anti-hemorrhagic also. It has got a 40 minutes half-life. And one IV bolus can take care of the uterus for about 16 hours of what you give as an infusion. Can you repeat the dose? Normally not required. If required, you can repeat after 1 hour, but there is no dose variation. Here comes, there is no 5 units, there is no 10 units, it's only 100 microgram, which is very, very standard. Carbetocin does not require any thermal control also. However, in our Indian scenario, we have started now using it, so we are not able to quantify on its usefulness presently with the comparative data. The contraindications for carbetocin also should be kept in mind, not in epileptic, not in cases of eclampsia, not before the delivery of the head, because in some of the cesarean cases, people start oxytocin in the drip, and caution in gestational hypertension also. Next in line oxytocics are the carboprost, prostaglandin group. And it can be repeated every 15 minutes up to a maximum dose of 8 doses. Rectal misoprostol is also very useful, especially in transferring the patient. In all these cases, keep the bladder empty with the Foley's catheter in situ. Methyl ergometyl maleate is the next drug of choice, which has been time immemorial use, and it can be given up to 5 doses, and it can also be given along with oxytocin infusion, also in case of atonia. The new approach is the tranexamic acid, about which Nivedita made a mention, and it is given at a fixed dose of 1 gram in 10 ml IV in 10 minutes, and it can be repeated after 30 minutes also. The National Health Mission has come out with this massage and oxytocin as a training called Dakshata training. I like the Jivandhara, which is being done by our FOGSI. Day 1 is AMTSL, day 2 is prevention and identification, day 3 is management with oxytocin. So the need of the hour is a long-acting drug, single drug, ease of administration, no receptor sensitization, superiority with a side effect. So taking you to the final leg of my presentation, active management AMTSL is a must. PPH is not preventable in all cases. However, you can predict also. All laborers should have a cervical inspection kit and a PPH box. Postpartum period should always be monitored, including the uterus, which is hard in the abdomen, should be monitored, and bleeding is within normal limits. Always shift the patient after she passes urine. Same applies to cesarean section also. Thank you very much for your patience. Hearing.
Thank you so much, ma'am. Coming from you, they are all pearls of wisdom that we are having today in all these talks. The essence of management of PPH. Dr. Manisha, ma'am, you are concluding.
Yes, yes, madam, you have nicely described the importance of the two very important components of active management, that is uterine massage and use of oxytocin. The first drug being oxytocin, and then the newer drug is Carbetocin, which is heat stable, and the AMTSL should be practiced in each and every labor. We should not miss even seconds after the delivery to prevent the PPH. And as you have already said, it is right. Uterine massage should be given every 10 minutes for 60 seconds, not for only a single massage will be useful. And regular drill, I want to impress upon is regular drill must be there for prevention and management of PPH, with PPH box ready in every hospital. Thank you, madam.
Thank you.
Thank you, Manisha, ma'am, for sharing. Can we have the next chairperson's CV? We have completed the AMTSL and the H, E, and M and O part of the hemostasis. So now we move on to ST, that is shift, transport, and the methods we employ to prevent or treat PPH while we are shifting and to OT or then transporting to tertiary centers. To chair this talk, we have a very senior obstetrician and gynecologist with us, Dr. Yashodhara Gaur Madam, who is President of MP State Chapter AGOI and West Zone Coordinator of FOGSI Oncology Committee. She is a Professor GR Medical College, Gwalior, Vice President of AMPOG, and she is a faculty, master trainer, and
thank you.
And many awards to her credit. Yashodhara ma'am, I request you to introduce our next speaker, Dr. Krishna Kumari Madam, for her talk.
Yes, madam, please show me her CV.
Yeah.
First of all, I am thankful to Dr. Kiranmai for making me a part of this prestigious webinar, the CME on PPH, and which is very, very important in we obstetricians' life. To speak on a topic of shifting the patient from labor room to OT after deciding that yes, this patient needs surgical intervention, very crucial moment. And this is not only physical time, but this time should be also used for planning and collecting our multidisciplinary team. Each and every person counts. And when life is at stake, every second counts. And to speak on such an important topic, my friend Dr. Professor Krishna Kumari, Madam is here, who is University Gold Medalist in MD, 30 years of with the clinical OBGYN practice, 25 years of teaching experience, and served as governing council member in ICOG, National Corresponding Editor of Jogi, National Coordinator of Megha, President OGSH in the year 1719, Secretary OGSH, Treasurer OGSH, Vice President Peacocks, a decade as scientific chair for OGSH conference, local, national, and international. Lot many work she has done, and of course she is the right person to speak on the transit time where patient, we decided that yes, this patient needs surgical intervention in OT. So very important point, time. So Dr. Krishna Kumari, madam, I hope everyone will get the benefit of her experience.
Thank you so much, Dr. Yashodhara. It was a pleasure having listened to the starting batsman, Dr. Nivedita. We had Dr. Mitra, and of course, my favorite, Dr. Jayam Kannan, ma'am. It was wonderful listening to all of them. Can I share my screen? Thank you for your kind introduction, Dr. Yashodhara, and it's a pleasure to be able to be a part of this very important, what I would say, series in the Quest program. And thank you, Shanta, and more specifically, the Vice Presidents in charge, Dr. Archana and Dr. Kavita, who I think Dr. Archana is going to be there with us today. It's a thank you for permitting me to be here. And without wasting time, I would like to move on to my topic. That is first S standing for Shift to OT and T for Transport Protocols and Tamponade. So this is again another, like Madam said, this is a story of a woman this has been given in the Saving Lives, Improving Mothers' Care, of an anemic woman who had a C-section. Blood was not kept ready. She has lost 1,000 ml of blood. Later on, she had almost 2,500 ml blood was lost. And they load, because blood was not ready, they loaded her with 8 liters of crystalloids and 2 liters of colloid. And then she developed pulmonary edema. She was intubated, ventilated, shifted to ICU. Finally, they lost her after a month. If you look into this case study, we know how many mistakes can happen and where all the mistakes can happen because it was not prepared. That's why we thought it is very important to keep on reiterating and talking about this particular aspect. And we all know that PPH is one of the fastest killers. It can kill as fast as 2 hours, although in the previous case it has taken 1 month. So it's very important that an early recognition has to be done. That is the most important point as far as PPH is concerned. And the 3 organs which are more susceptible are the anterior pituitary, the kidney, and the lungs. And we all know that 40% die at level 1 facilities and 50% happen because of because the facilities are not adequate and within the first 24 hours. And so the government of India has given us a framework along with FOGSI, and they have made certain requirements which should be there for managing a case and prevent and to be under this category of birth preparedness. So this, I think everybody can just download and have a look at this particular framework, which has been done by Dr. Sanjay Gupte and Dr. Suchitra Pandit when they were holding fort in the FOGSI. So it's very important that we understand the limitations we have at the center we are working. That is one of the most important things that has to be known. And there have been appropriate referrals at the appropriate time, unless you are in a tertiary care center, is the most important thing that has to be identified and to be done to bring down this mortality or morbidity to much lower levels. So how do you identify these cases which are going into PPH? We have the MEOS, we have the yellow alert, which were 2 of the markers, and the red alert, 1 of the markers, which can tell us. And it's very easy to have this chart in place and to know when this woman is going into a more severe form of PPH and where intervention has to be done more actively, whether there are limitations in your setup or you can go ahead. And much more simpler is a shock index, where we are just looking at the ratio of heart rate to systolic blood pressure. But we have to remember that the range is a little higher because of the different dynamics as far as the physiology is concerned in a pregnant woman. So shock index in a pregnant woman is slightly higher, that is 0.7 to 0.9. This is a very simple way, HR2 systolic blood pressure. So that's an easy way anybody can do, where they can recognize the early points where the woman is likely to go into a shock. So there is a quick initial assessment and appropriate referral form, and for that all these factors have to be kept ready, some of which have been already mentioned by my predecessors: to start the basic treatment, call for help, have the ABC in place, to start with fluids, monitoring of the patient, catheterizing her, keeping blood ready, taking an informed consent. And of course, if with the infusion, you have the uterine massage, compression, aortic compression, as well as the bilateral uterine compression, the tamponates, and the anti-shock garments. These are the minimum things which everybody should be able to do when they are tackling a patient, because PPH cannot always be anticipated. So it is always, we should be ready to transfer the patient whenever we have a problem, especially to a higher referral center. And it is very important that a woman when she is bleeding, to also follow certain principles like elevating her legs, keeping her warm, and keeping her airway intact, and then starting her on NSG and doing a massage even while transporting the patient. And the recommendations are there even for an effective advanced referral system, where you should know that you should have a proper transport mechanism. You be sure of the place where you are transferring the patient, if it is adequate enough to accept your patient. It's just not important to just send the patient out of your hospital, but it is also important to identify the particular place where you are sending the patient to, and don't send the patient with a slip of paper saying that this patient is referred. Please see that there are a list of referral documents which should be kept in place, and they should be filled in and sent along with the patient, along with a person or an individual who would be taking care of the patient and doing a massage while the patient is being transferred. So please see that your referral documents are very, very, very well placed before you refer any patient. Then coming to the place of aortic compression, we all know that it is very important to learn the technique of aortic compression. It is very simple. With the aorta, we know it bifurcates almost at the level of the umbilicus, but at the umbilicus, it can go up and down in a pregnant woman, especially when the abdomen is lax. So it is very important that you also palpate the femoral artery when you apply aortic compression to see whether your compression is effective or not. This is a pictorial representation of the same. Then you also have, you cannot go on putting a compression or doing a massage continuously when you're transporting a patient to a longer distance. I think in such circumstances, it's very important that all of your ambulances are provided with a non-pneumatic anti-shock garment. And the anti-shock garment has shown to reduce blood loss by 50 to 78%, as well as the maternal mortality has reduced because of it. It is cost effective, and more important, in a country like ours, it is reusable. So there are special steps of how you apply it, starting from the ankles, move upwards and to the lower portion of the rib. The different flaps are applied, and then and how to when to remove. Also, there are specific guidelines. That is, the patient should be stable for 2 hours, the bleeding should be minimal, pulse should be stable, blood pressure, high hemoglobin should be stabilized more than 7 grams. Patient should be conscious and aware. And until then, you please do not be in a hurry to remove the NASG. If this fails, then you have 2 options, going for surgery or for medical management. And it depends again on the choice, whether you want to do a cesarean or you want to post-vaginal delivery patient. So based on that, you can choose the method of whether going for tamponade or compression sutures. So when we are looking at tamponade, which is I think compression sutures are coming later, there are lots of indications where intrauterine balloon tamponade has been proved to be effective in many conditions to prevent PPH. but also it is important that you know how to use it. There are a huge range of them. We all have used Bakri balloon and we have seen it has been quite effective. A lot of papers which say that it has been very effective in controlling the bleeding, especially after vaginal delivery. The tamponade works very well. Maybe compression sutures would come when you have already opened the abdomen, but for a vaginal delivery, it is the balloon tamponade which should be tried first. And a tamponade test should always follow application of a of the balloon, and then you have to see whether it is positive or negative. If it is a positive test, that means that further you can wait and watch, but at the same time parallelly observe the vital signs, because there might be some internal bleeding or in spite of the tamponade. Then this is how the Cook Bakri balloon looks like. And this, for those I'm also working in a medical college where affordability is an issue, and I think here the Chhattisgarh balloon, which has been I think started by our own very people, I think we should appreciate their ingenious way of starting this, and it's really working well. I've used it quite a number of times in my setup also in the college. So when we're looking at analysis of 91 studies, the meta-analysis of 4,729 women, the uterine balloon tamponade was successful in 85.9%. And the more it was more successful when the bleeding was due to uterine atony and placenta previa. So these were the bestest indications for the usage of uterine tamponade. And of course, like we already said, more successful in vaginal deliveries when compared to the cesarean section. And this is extensive work again done by California Maternal Quality Care Collaborative, who also say that there can be a concealed intra-abdominal bleeding. So please look out for the unrepaired lacerations before you place the balloon, and to also monitor vital signs closely even after placement, even when the visible amount of bleeding is reduced or eliminated. So there is uterine packing, but from 2012, the WHO is not recommending uterine packing. But it can be used in certain circumstances where the patient has to be shifted. And now we also have a long continuous gauze or thrombin impregnated Carbetocin covered gauze. It has been useful, it has proved useful previously and now also in certain circumstances, but not recommended by WHO as of now. So like Sibai always says, you have to stay ahead of bleeding, start early, and do not wait for lab results. Fill the tank, find leaking holes, squeeze, compress, ligate, balloon, suture. And ileal surgery is not a routine. You also should know where your level of your facilities stand, identify your level, and then please see what your limitations are. And an early recognition and transfer would be what I would recommend at this stage. So to conclude, I would say the use of intrauterine balloon tamponade is recommended for the treatment of uterine atony. It can be used for women who do not respond to uterotonics and are not available, or if they are not available. This procedure can be appropriate while awaiting transfer to a higher level facility. Since Bakri is expensive, find something which is more acceptable in your setup. And you can also have advanced skill labs in your and training centers at your own place. And bimanual uterine compression and external aortic compression due to atony after vaginal birth is recommended for transfer. Use of uterine packing is not recommended as of now by the WHO. So thank you all for your patient hearing. I hope, Kiran, I kept my time. So thank you one and all.
Thank you, ma'am. You were on time, except the conclusions. So I request our chairperson to take few comments. Next is, yes, ma'am, Yashodhara.
Yes, Dr. Kiran Bhai, a very comprehensive talk you have given. And you rightly mentioned that we should use MEOS and shock index. And we should keep our level of suspicion high that this patient, all those patients where risk of postpartum hemorrhage is there, we should remain alert. And IV fluid, as far as you have said, that IV fluid given is very important. At least 1 to 2 liter fluid should be given while patient is in labor and patient is in third stage, and we are managing PPH. And because it will help us in reducing the chances of pituitary hypoxia and kidney damage. And so IV fluid, usually what happens, people don't give much attention to IV fluid replacement. So it is where we have to focus. And at the same time, as you have said, that aortic compression and anti-shock garment and uterine balloon insertion, and these all the entities, they need expertise in using in emergency hours. So repeated drills and practice is required in these components. And as far as when we transfer the patient to any higher center, it's very important to give the procedure, what you have performed, what drugs you have given. Here I will take 1 minute only, Dr. Kiranmai. I want to share one case which was transferred to us as a case of PPH in our hospital, and the senior resident has seen this case, and immediately they put one balloon, uterine balloon for tamponade. But what happened, we saw that though there is no blood coming from the uterine balloon, but uterus, as the height of the uterus has started rising, and patient's vitals were deteriorating. So immediately we performed one ultrasonography, and ultrasonography didn't give us much information, but MRI was done, and it was found that there was a compression suture was present in the uterus. And that compression suture, not only it was compressing the upper segment, and in upper segment blood is getting collected, and there was opening in the stitches was also present. So since there was no information given to us by the doctor, by the referring obstetrician, that this patient is having compression suture, that's why the balloon which was put was in the cervix. So immediately then we removed that balloon, and we took the patient for laparotomy and removed those compression sutures and managed that patient. So it's very important to give whatever be the procedure has been done in the periphery, in the district hospital. Whenever you refer a patient, give a detailed information, or at least you can contact on phone and give information that what you have done. Thank you, Dr. Kiranmai, for giving me this opportunity and for giving me time to speak.
Thank you, Krishna madam. That was wonderful talk. Thank you, Yashodhara ma'am. Actually, we had the next talk by Dr. Bellard. Unfortunately, because of internet issues, he's not able to join. I also request Yashodhara ma'am to introduce our next speaker, none other than our Dr. Niranjan Chavan. Can we have Dr. Niranjan Chavan's CV? Venkatesh? Yeah.
Yes, Dr. Niranjan Chavan, all the very well-known name, and in FOGSI in our country, everyone, most of us know him very well. And Dr. Chavan is Professor and Unit Chief, LTMC and LTMGH 7 Hospital, Joint Treasurer FOGSI in the year 2021-24, Vice President MOGS 21-22, Member Oncology Committee SEPOC 2022, and Dean AGOG and Chief Content Director of High Grade and Famous Courses, Editor-in-Chief of Famous TOA and ICO, JGOG General, and 47 publication is there in his name. National Coordinator, FOGSI Medical Disorders in Pregnancy Committee, Chief and Convener of FOGSI Cell Violence Against Doctors, Member Oncology Committee. He is coordinator of 11 batches of MUHS, recognized certificate courses of MIE, and member of Managing Committee IAGE, Editorial Board European Journal of Gynec Oncology Italy, course coordinator of 3 batches of Advanced Minimal Access Gynec Surgery at LTMGH. So Dr. Niranjan Chavan is a very well known name and known person to all of us. I invite Dr. Niranjan to deliver his talk.
Thank you so much. At the outset, I would like to thank Dr. Shanta Kumari for getting this ball rolling for the FOGSI Quest CME. This is the number 2, and I would like to take this opportunity to thank the conveners, Dr. Krishna Kumari Meka and Professor Kiranmay Devneni. They have taken a lot of efforts and pain. Thank you, Dr. Gaur Yashodhara, to introduce me so nicely, and I would like to take this opportunity to thank all of you. So with this, I would like to share my screen now. My topic is I and S of hemostasis. I hope you can see my presentation now, which is open to all of you. So this is welcome to the FOGSI Virtual CME Quest Series 2 Tackling PPH. Your time starts now. I would like to apologize that I was late today because I was with my family, and I just entered my residence for the presentation. So thank you all of you. These are the big names which are there present for this virtual CME, and you have been so kind and nice to give me this opportunity. So before me there were so many of the speakers, well-known speakers from all over India, who have already tutored you about hemostasis, and I am the last. I don't know why I'm the last, but probably they thought I am the most the best person dealing with Sion Hospital. Well, we have 14,000 deliveries a year, and we get 50% of transferred cases from the Western and Eastern Express Highway in the city of Mumbai. I am presently practicing for 31 years in a institute which is known as the Sion Hospital, or it is commonly known as Sion Hospital, and it caters to the largest slum area of Asia, that is Dharavi. So you have seen Gully Boy. So there I come from, Gully Boy, and I can see the smile on people who can reciprocate the same. But we are here for teaching of the obstetricians how they can tackle the situation when they land up with such a situation of hemostasis. So we all know what is this hemostasis. So it's been covered. I'm going to talk about INS, that is interventional radiology, subtotal or total hysterectomy. In our intervention radiology department, we have Dr. Anaga Joshi and Dr. Vivek Okirde, who have been doing a lot of pioneering works. I would like to share some of the videos and the slides with them, which we have reciprocated together when we get such cases of atonic PPH or a placenta percrita or a creta. So intervention radiology plays a very important role, and it is to be applied for institutional management. It is a very minimal invasive procedure. I know you require a lot of high-tech situation in there, and target intervention has to be done, and it shows the result of the intervention. So what we do, we have the uterine artery. So I want to trace this wonderful photograph which is there on the right hand side. You can see my arrow which is at the common iliac. It bifurcates into the aorta, which bifurcates into the common iliac, and then there is an internal iliac artery, and there is an external iliac artery, and there are further branches which you can see. The uterine artery which goes here, this is the uterine artery, and this is the access takes place to the femoral artery, and you get a wonderful picture of this angiography of all the vessels which can be seen. And what do? You do a gel foam embolization of the uterine arteries. Now I am going to take you through all these pictures from the left to the right on the top. This is a picture where you see the dye being introduced, and you can see the bifurcation of the common iliac into the internal iliac. This is the internal iliac and the further uterine arteries and its tributaries and the capillaries which you can see. This is the external iliac. And now once you see there is a gel foam being introduced, and when the gel foam is introduced, all these things is vanished. You don't find any blood supply going towards the uterus. So this is the magic what an intervention radiologist in collaboration with the Department of Obstetrics and Gynecology can do. And this is what you see, the picture on the lower bottom where the gel foam is in, and these are the particles. If you see the right extreme lower picture, my arrow is showing these are the gel foam particles which are introduced, and now you find the obliteration of the uterine artery and the capillaries are not seen. So basically it causes the distal occlusion and that prevents the arterial reconstitution. There is a temporary occlusive effect which is for 10 to 30 days. It is quite rapid and it's available at all the time and it can be done within less 1 hour. This is the success rate which have been collaborated and read by so many authors from 1987 till now, and overall success rate of this to control postpartum hemorrhage is 90 to 95%. I want to play this video for you. You can see this. We will go one by one. There is an introduction of the catheter which goes through the femoral artery. It goes further into the common iliac, then it traverses into the U-shaped up, it goes into the internal iliac, and now the coil is seen. It will be released now, and once it is released you find that there is no blood supply here. So this is the coil. So you have two things, one is a coil, one is a gel foam. This is another uterine artery coil embolization which is being seen here. Yes, this is the post iliac artery coiling. I am going to play this video. So now following this coiling, what do you see? There is nothing being seen. You don't find any blood vessels being there with blood supply. This is the coil which has been put. It is a platinum coil and it undergoes itself revascularization with a fibroblast being developing on that, and it causes an occlusion of that vessel, and that's what you see here nicely. I will play this video again. See this, the coil has been placed and now you see at the distal end the blood supply is gone. Can you appreciate that? If someone can say yes, I would appreciate that you have understood. Thank you. So everyone has understood. So this is what is the presentation which we come across when we do a coiling. So the normal menstruation resumes in 3 to 6 months. Complications are very uncommon. It is to be a specific, a skilled, a specialized modality which has to be available in your institute. But you should remember that you reduce the complication rate of laparotomy, etc. But there is something like fever, abdominal pain and leukocytosis, that is a post-embolization syndrome. It takes place for about 2 to 3 days, it goes away. There could be an access site hematoma at the femoral artery. Infection is a possibility, but you always cover them with an antibiotic. Ischemic complications are very, very rare. It could lead to nerve paralysis or bladder or uterine necrosis. And there's something like placenta accretal syndrome and PPH is noted in future pregnancies. So this we have to understand. I want to collaborate it with the certain articles which have been published, and it has been well known by me, Christine, in 2015. There is a decrease in the incidence of postpartum hysterectomy since the introduction of UAE, and the clinical success rate, that is out of 34 patients, 28%, that is 82% of them had a clinical success. So it's quite good, and none were re-embolized. However, there is a higher recurrence of rate of PPH after the previous UAE was observed. This is another in March 2021, the latest last year, where a systematic review and meta-analysis of obstetric and maternal outcomes after prior uterine artery embolization was done by Shinya Matsuzaki et al. In Japan. And this was analysis which was based on the presence of prior PPH. Women with prior UAE were associated with higher rates of PAS and PPH. So this is what we should understand. Well, what are the advantages if you compare with selective devascularization, systematic devascularization or a hysterectomy? It is less invasive, less morbid, it's quite immediate, no adverse effect, and embolization is usually successful. So this is a wonderful picture you can see, where you can see the aorta, the common iliac, the internal and the external iliac, and we introduce the gel foam or the coil there, and embolotherapy is done. It's a best option which can be given for a patient if you have this setup and the presentations with the skilled radiologists being there. So this is the collaboration of an obstetrician and intervention radiologist, and of course it will reduce your incidence of hysterectomy. However, if you do not have this facility in your hospital and there is no other option, you have to have a subtotal or a total hysterectomy depending upon the patient's condition, and this will be the definitive treatment. You have to go in and go out fast. You can't waste time. You have to be there. The pulse of the patient is steady, the blood pressure has fallen down to 90/40 or 90/50. You cannot allow it to go down. You need to do a decision making. You can't just give misoprostol, methergine, carbetocin, prostaglandins, intramuscular, intramyometril, and you just go and waste your time. No, you should decide fast, take a consent, explain the relatives that this is a near death situation. It is a death on table, and this patient can only be salvaged by doing a hysterectomy by you, and you are the only person who can do this before the DIC or the urine becomes high colored, or hematuria sets in, or the platelet count is very low. So you have to understand, then your success rate of doing a hysterectomy and saving the mother's life is very important. So I hope you can understand that. Thank you for that, Bell. Just give me 1 minute.
Sure,
Thank
sir.
you so much. Thank you. Just give me 1 minute. So in patients with placenta accreta, spectrum, and uterine rupture, you need to do a hysterectomy, and these are the live specimens which have been done in my hospital at Sion Hospital, where we have done this hysterectomy, and there is no delay. It is very effective. However, the patient will not be able to conceive after this. You need to understand and achieve resecure the suturing, the point. So you have to see that the blood pressure is again coming up. You need to also resecure the pedicles which you have taken, that is the infundibulous pelvic. If you need to remove the ovaries, but if you do not want to remove the ovaries, you need to preserve the ovaries. You have to take out the cornual structures, the uterine artery, and the uterosacrals, and that is what the pedicles have to be secured onto the right hand side. You can see, and do a fertility preserving procedure. So my take home message is that you have to individualize the case, choose the appropriate therapy depending upon what the facility you have available with you, either an embolization or a hysterectomy in a worst scenario of a patient coming with atonic PPH, and it is not helping with conservative or a medical line of treatment. This is the only option which you can see, that is UAE or a total or a subtotal hysterectomy. Thank you so much for a patient hearing.
Thank you, sir, for that wonderful deliberation. You have packed so much into 10 minutes, all the essence of your experience as a professor at one of the busiest tertiary hospitals. I request Dr. Preeti Kumar, thank you for joining us, though you were really busy in your son's admission and all.
Thank you
Dr.
so much.
Preeti, kindly conclude this. We
Thank
move
you
on
so
to the
much.
inauguration.
Thank you so much, Kiranmai. It's a privilege and honor to comment on Dr. Niranjan's talk. Dr. Niranjan, you were so good in your deliberation, and you know why this talk was given at the end, because experts usually come at the end. So you are an expert and you are working in a tertiary hospital. So we needed your opinion, and wonderful deliberation on interventional radiology and subtotal hysterectomy. So prompt decision and prompt action saves the life of a mother. So that's the main message that should be given through this session. Thank you so much, Niranjan. Wonderful.
Thank you. And I see Dr. Madhuri Patel and so many eminent people here, there Mitra Saxena and others, to join me together for this wonderful FOGSI Quest CME, and I wish all of them best wishes. Thank you so much.
Thank you, sir. With this, I hand over without further delay to our convener, Dr. Krishna Kumari Madam, to take us into the next very important. I have seen Dr. Sanjay Gupta sir and Prakash Trivedi sir are already joined. And ma'am, please go ahead with the inauguration.
Thank you.
Shanta Madam has joined.
She's joining, Kiran.
Has she landed? Okay.
Yes, ma'am.
Okay.
She's joining. She's in the car.
Yeah. Thank you. Thank you so much, Kiran. It was a wonderful session we had. I think it was a very beautiful session right in the beginning, and we have much more ahead of in the program. And we are going ahead with the inauguration in the time being. And for this, I would like to invite all our special guests today. And this privilege of inviting and welcoming the guests, I want Dr. Archana Verma, our very charming, friendly, sweet Vice President. Where are you, Dr. Archana? Are you there?
Yes, hello, I'm there.
Hi. Yeah, so it's a pleasure to invite you to welcome all our faculty, our guests, as well as the delegates for this session.
Madam, if I may interrupt, when Archana Verma comes, you can see the smile on everyone's face and the radiance which she gives to everyone. And I can see Prakash Trivedi, Madhuri Madam, and Aruna Suman, I mean, I can just go on and on, but thank you so much. Sanjay Gupte also has, Gupte sir has also joined. Thank you so much, Madam, for being there.
Thank you, Dr. Niranjan, and thank you, Dr. Krishna Kumari, the wonderful coordinators for today's virtual CME. And today's my proud privilege and honor to welcome you all for this postpartum hemorrhage and management, this CME. And see, my greetings to all. And I think with the this perspiration and all those problems and in the PPH, and we want to go for the happiness. So all these challenges, we all know. And I welcome our FOGSI President, Dr. Shanta Kumari, and all guest of honors, Dr. Sanjay Gupte, Dr. Prakash Trivedi, the great past FOGSI presidents, and FOGSI Secretary General, Dr. Madhuri Patel, and all the FOGSI respected seniors, colleagues, delegates, and all the FOGSI office bearers, of course, Dr. Suvarna Khadwikar, Dr. Niranjan Chavan, the great, and Dr. Parikshit Tank. And I just want to convey my message also with the welcome a little bit because the PPH makes everybody so worried, so anxious. So we should remember एक शेर तो मैं जरूर कहूंगी. ये और बात है कि आंधी और तूफान हमारे बस की बात नहीं, पर दिया जलाना तो हमारे अख्तियार में है. Like we should do whatever we can do because although we cannot prevent PPH, but definitely we can prevent the PPH deaths. And India MMR, although we are seeing the declining rates, and all these efforts of FOGSI never go waste. And so this our presidential e-conference is all about awareing all the people about how the all the skilled health professionals should do and what we expect from the community. And because the special group of people who are at risk and vulnerable, this is a basic theme, a step for any management for any disaster. And if we recognize the high risk patients and the would-be victims, then we can do much better. And because the poor facility and the poor access to facility are the poor people, the low socioeconomic person, they are with a simple small jug, they fell down like anything. So each health professional must communicate and understand that community awareness and making them responsible for decision making for birth preparedness, as very well said by Dr. Krishna. And they never underestimate the power of time, as told by Dr. Jaya Madam, because each minute has 60 seconds for action, and more than 2 hours delay is dangerous. And this each drop of the blood matters, and well-informed patient is our responsibility. And I think the FOGSI is doing very well, and I welcome you all, please all.
Thank you very much, Dr. Archana. I would also like to thank Dr. Kavita, who's also in charge of this particular program. I think she could not join us today, but thank you both of you for your wonderful contribution in making this PCOS.
Thank you for giving us opportunity. This PPH is very close to my heart, and all the Preeti and everybody say, I think you people are this time the FOGSI President Madam has given us so much opportunity, and we are all so happily doing all the work, and we need blessings of all.
Thank you, Dr. Archana. Can we have the invocation, please?
The sound is not audible. Yeah. Please share again, Venkatesh. The volume was not good.
1 second now.
हम लोग खुद ही गा लेते हैं। शुभम करोत्यं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोस्तुते दीपज्योतिर्नमोस्तुते।
Venkat, can you play us the president's video right now?
1 second.
Dear friends, FOGSians and women of my country, I am Dr. Shanta Kumari, President of the Federation of Obstetrics and Gynecological Societies of India. As a little girl, I told myself that I have to become something to make a difference. I always believed that if I desired something wholeheartedly, there is a positive force which makes it happen. And here I am, friends, standing in front of you as the 60th President of FOGSI, the 38,000 strong committed body of OB-GYNs taking care of women's health in our country. As a young girl, I realized that women play a key role in this world, just like Mother Nature or Stree Shakti as we revere it. It is a guiding force behind all forms of God's creation. And it's only a woman who can actually create a new life.
Hi, I'm Kareena Kapoor Khan and I'm so happy to be here with you, if only on video. Pregnancy is a beautiful experience and I have loved having my babies. I congratulate Dr. Shanta Kumari as taking over the 60th president of this eminent organization.
Stree Shakti is the embodiment of 5 elements: the sky, the air, the water, the earth and the fire. Any imbalance in any of these 5 elements creates chaos and calamities. Similarly, when a woman's health is neglected, it disrupts the universal equilibrium. The intimate link between environment and human well-being is very well known. With increasing awareness of the need for clean water, pollution-free air and pesticide-free food.
Hi, I'm PV Sindhu. Well, it's such a beautiful feeling for me to be an empowered girl, to be a girl in a nurtured and a safe environment.
Protecting health by preserving nature and its ecosystem is easier than curing any disease. So we have taken up the concept of minimizing the female morbidity and mortality and fetal effects by mitigating the adverse impact of environment. My theme this year goes beyond FOGSI's commitment towards women's healthcare. FOGSI for all always.
FOGSI for all is another inspiring
women.
Cricket, can we go ahead with the rest of the program? Do we have our President, Dr. Shanta Kumari, joining us?
Yes, ma'am. She already joined.
Yeah. Can I now invite Dr. Shanta Kumari to address all the members who are present today? I think Dr. Shanta Kumari needs no introduction. And
thank you.
I know. I've stopped. I'm waiting for you only. Yeah, please go ahead, Dr. Shanta.
Good afternoon, everyone. I can see Dr. Sanjay Gupta sir, Dr. Prakash Trivedi sir, and my dear friends Archana Verma and Niranjan Chavan, and of course my Secretary General, dear Dr. Madhuri Patel, and all the seniors and friends who have joined. I can see Dr. Jayam Kannan Madam also. So it's indeed a pleasure to have all of you here. And yeah, this quest series we actually thought, we really thought in January that we have moved away from the online programs. Then suddenly we were hit by the third wave. So then we thought probably we need to have once in a way a bit of online interactions. And when we were wondering what were the topics, we realized PPH is still an important topic which we need to touch now and then, so that we are always in, I think, in attention when it comes to handling PPH. So I'm sure that this program will enable all of us to refresh all our skills and drills. And I would really like to thank our faculty who have joined us today. And of course, Sanjay sir and Prakash Trivedi sir, for always being very cooperative and never say no. So, and being with us. Thank you very much, sir, and everyone. And I'm sure that this program will benefit all the delegates who are logged in today, and wish you all the very best for a happy weekend. And hopefully we'll all meet and see each other in Indore soon. And right now I am in Baroda, just landed in Baroda to deliver an oration at the Baroda OB-GYN Society. So nice to see our own people in person. Looking forward to meeting all of you soon. Bye, friends.
Thank you. Thank you, Shanta. Have a wonderful oration. We wish you all the best, and we are all with you. Shall we move on to the rest of the program? I think we'll go ahead. Yeah. For the next session, I invite Dr. Sanjay Gupta sir. He is our guest of honor. And similar to Shanta, and we all know that Dr. Sanjay Gupta sir does not need any introduction, but I think on a formally, I would love to introduce him. Can I have his CV, please?
Actually, there is no need for the formal introduction. I am traveling and I may lose the connection, so I
please
must
go ahead,
express
sir. We'll keep your slide intact.
I'm very happy to be here, and this is such an important topic, and we have been, discussing and working on these topics for years together. But every effort is important to save the mother's life. It was so nice to listen to Niranjan and Jayam and Mitra and all, very good, talks. And I'll try and keep connected, if my connection allows, while traveling. So thank you so much, for having me here.
Thank you. Thank you so much, sir. I think would you like to say something?
I think Sanjay Gupta sir is also traveling like me, and he has lost connection.
Can we have Prakash Trivedi?
Dr. Prakash Trivedi.
Slide, please.
Of honor. Yeah. So I think Dr. Prakash Trivedi also doesn't need any introduction. He is known to all of us.
Krishna Kumari skipped the slide.
Okay, so please, over to you. You can say whatever you want to say on this particular topic. No. I think it would be more of a pleasure listening to you.
Prakash sir, before you begin, I would like to tell one important point. We all know Prakash Trivedi sir as the President FOGSI, And we all know him as an endoscopic surgeon. If you hear his name, we'll remember endoscopy. But when he became the president, FOGSI, the conference he said will be his presidential conference, which was in Hyderabad, one of the important conferences, was on obstetrics. And he made sure that this will be attended by many delegates. And sir, you have shown that even though you're an endoscopist or an infertility specialist, what is very important for the country is obstetrics and management and taking care of our mothers. Thank you, sir.
Thank you, Shanta, Madam Kiranmai and Krishna Kumari, and all the legends are sitting. Where all the legends are sitting. I heard many talks. In fact, it was education to me also. PPH is, of course, very important. Only one situation I remember was in Ahmedabad, wherein quickly reaching to the uterine was done laparoscopically in a patient for PPH, and everything got straightened up. So it is interesting to hear all of you. There are so many people. If I start naming, then it will go like an introduction. It is truly an honor to be in this position in such a wonderful FOGSI event on PPH. So thank you very much. Enjoy the program. I am in good connectivity. And Archana ji's moment आया, smile चालू हो गया, निरंजन का भी smile चालू हो गया, सबका. So I am very delighted because this still remains a very close subject to all of us. Thank you very much.
Thank you. Thank you very much. I think it is our privilege that we have a specialist on medical legal issues and justices, and the specialist who is so much into endoscopy, being with us today as guests of honor and giving us their perspective of how important postpartum hemorrhage is to all obstetricians over the country. So thank you, both of you, for being with us and spending this evening with us. And it's a pleasure having both of you. I now would like to invite our very sweet and charming Secretary General, Dr. Madhuri Patel, for her vote of thanks. And I'm sure she would say no.
Yes, no.
Yeah,
I know my slide. Thank you very much.
Yeah.
I think we can go on a gallery view if you can take out my slide, So I would like to see everybody. Respected all the dignitaries on DS and of the DS. Very good evening to all of you. At the outset, I would like to thank Dr. Shanta Kumari and team for giving me this opportunity. I was asked not only to give a vote of thanks, but also my message. So I would like to mention in my message that PPH is the most, quickest killer of the normal mother. Patient can die within 2 hours if not treated adequately. And I would like to mention that majority of them are preventable because these are the atonic PPH which are preventable. And I represent FOGSI in the MDSR meeting, that is maternal death surveillance and response, and what we call as quality assurance, meeting at Mumbai district, and I represent FOGSI, and I have been going over this since last 6 years every monthly. And what I have found that about 12% of the mothers die because of postpartum hemorrhage, where all the facilities in Mumbai are available. In spite of that, it died. But when we analyzed, we found that majority of them are a referral patient out of Mumbai. And what I have observed, that when there is a moderate to severe PPH, we all are there to, use our, all the gadgets, our, expertise and save the mother. But what I have realized and observed, that minimum bleeding, that is tickle bleeding, which has been not noticed by many of our obstetrician and the paramedical, and the patients are diagnosed only when they go into hypovolemic shock, when it is too late. So my simple message to this is that atonic PPH are preventable. 70% of the patient are preventable, because we always consider high risk patient as an atonic PPH, but then low risk patient also can end up with atonic postpartum hemorrhage. So we as an obstetrician has to be prepared for not only preventive aspect, but also the treatment aspect, where we have to be very, very quick. And you have to vigilant to observe these, minimal bleeding or surgical bleeding, so we can catch this patient at the right time and we can treat them. And now I would like to give, after giving this message, I would like to, to give the vote of thanks. And on behalf of FOGSI team, I'm really honored to propose a vote of thanks. We would like to thank and congratulate our most dynamic president, Dr. Shanta Kumari, for conceptualizing and implementing effectively the Quest series tackling PPH, your time to start now. So really, this is a very, very good heading, and it is a very catchy and very effective. We would like to thank our guest of honor, Dr. Sanjay Gupta sir, another dynamic past president FOGSI, internationally acclaimed, and he's always there to guide and advise her for anything in FOGSI, and especially in the medical legal issue, and we are aware about that. And I would like to mention over here that when I took over as a Secretary General FOGSI, sir came and gave me confidence along with CN sir and PK sir and Prakash sir, that anything you require, please let me know. We are always there. So thank you, sir, for your advice and time to time guidance. And thank you for being here today with us. Then our another dynamic, most sincere, dynamic, meticulous and the great leader. We would like to thank our past president FOGSI, Dr. Prakash Trivedi, and past president of, IIG, and present presidents of, ISA. Sir, you are absolutely meticulous. I've seen your surgery, I have seen your presentation, and as rightly said, you are endoscopic surgeon, but he is master of all, I will tell you. And he is not only in endoscopy, he's in IVF, he's in obstetrics, sir. Thank you very much for being with us. Thank you very much, sir. Then, of course, I would also like to thank all our esteemed speakers. We have heard Dr. Jayam. I was there after Dr. Jayam Kanan has come, Dr. Niranjan, and of course Priti Kumar and Dr. Mitra I could not hear, and we will be hearing Dr. Hema, Dr. Mrutyunjay, and Pratima Mittal. Pratima, I could not hear you, and other speakers and chairperson who are going to give us, they have enlightened and they are going to enlighten us on this topic, which is definitely going to help us in day-to-day practice to achieve our sustainable development goal of reduction of maternal mortality rate less than 70 per 100,000 live birth by 2030. Of course, we would like to thank all our office bearers, especially Dr. Rishikesh Pai, President-elect FOGSI, Dr. Alpesh Gandhi, immediate past President FOGSI. Then our VPs, Dr. Archana, we all have heard, and we smile. We all smile. When she smiles, we all smile. You can see here, everybody is smiling. Archana, thank you for with PPH. Smile is very, very important. So that indicates that we are really effectively treating our patient of PPH. Then Dr. Bipin, Dr. Basab, Dr. Kavita, Dr. Fesi, our Deputy Secretary General, Dr. Suvarna, Dr. Parishit, Treasurer, Dr. Niranjan, Joint Treasurer, Dr. Aruna Suman, Joint Secretary, and our convener, Professor Krishna Kumari, co-convener, Professor Kiran May, who have all worked hard to make this virtual event, successful and memorable. Of course, we would like to thank all the esteemed delegates who have joined with us virtually with a great enthusiasm and making this event a grand success. We would also like to thank our Tirupati. We cannot forget Tirupati and his team for the technical support, and without him, we really would not have gone ahead with this virtual program, and he has really given us, flawless, webinar. And I thank all of you for giving me this opportunity. Thank you.
Thank you so much, Dr. Madhuri. As usual, you have been sweet and charming. Thank you so much. With this, we close down the inaugural session. and move on to the scientific session. And for the first session, we have with us none other than another past president, Dr. Hema Divakar, talking to us about a very interesting topic, that is the new oxytocin, that is the age-stable Carbetocin. And for that, to share the session.
Krishna ma'am, yeah, sorry for interrupting you. We have had Dr. Mrutyunjay Bellad who had to join little late because of emergency.
Shall we do
So
that?
after Hema madam's talk, we can have that.
Sure. Okay, for Dr. Hema Divakar's introduction, I would like to invite Dr. Ragini Agarwal as the chairperson. Can we have the CV of Dr. Ragini Agarwal? Yes. Thank you so much. She is a fellow in clinical gynae endoscopy from UK and has done a master course in cosmetic gynecology and laser. She is a clinical director of OBGYN and MAS at head and department of cosmetic gynecology and pelvic reconstructive surgery, Praniksha Hospital, Gurgaon. She is also the director of Dermascience, Complete Clinic for Women Health, Gurgaon. And we all know she has been the vice president FOGSI 2020, the IMA Haryana chairperson for academic and public health education, president Indian Academy of Cosmetic Dermatology and Gynecology, and founder Gurgaon OB-GYN Societies. She has been carrying many hats, and as importantly, she is now the project director of GOGS Rural Maternal and Adolescent Girl Health Mission from 2012 to 2014, and project director of Pratiksha Women Cancer Prevention Awareness and APJ Abdul Kalam Award for Academic Excellence, and a member of the Lioness Club. She is a chairperson of Public Health Education Project, Lioness Club, Ojashwini. Over to you, Dr. Ragini Agarwal, to introduce Dr. Hema Divakar and her topic and take it further. Thank you
so much for your kind introduction. And it is my proud privilege to be part of such a great seminar, which is on the PPH, a nightmare of the obstetrician. And it is my pleasant duty to introduce none other than our own beloved past president, Dr. Hema Divakar, who really needs no introduction, but I have to do my duty, pleasant duty. Madam is the CEO and the chairman artist, and she is a dean of KCOG. She's a vice chair for FIGO PNCD committee 2015 till date, and elected as a chair of a Well Women Healthcare and advocate for delivering quality healthcare convener Manyata. What I can say about Madam, these are things, she has many awards. She is a very down-to-earth person, very knowledgeable, easily approachable, always and always smiling. So dear friends, on this occasion, I am presenting you none other than one and only Dr. Hema Divakar. Let's continue our academic feast. Over to you, Madam. Welcome.
Thank you, Ragini. Namaskar, everyone. FOGSI for all, always. I can hear it loud and clear from our president, Dr. Shanta Kumari, amply echoed by Archana Verma, the vice president, and Madhuri Patel, the secretary general, the past presidents, Sanjay, Prakash, and many other very distinguished and accomplished friends and colleagues who are here. And thanks to the very kind invitation by Kiran Mai and very well supported by Krishna, as I can see, the conduct of this flawless event, where we always say that many programs on PPH we've done. But dear friends, every program counts, just like every mother counts, every child counts, and every drop of blood counts. And that is where we are trying to see, in the quest of search for better and better ways of caring, the newer and newer molecules that may appear on the horizon. Do we really need the change for the major contributor to the PPH in the form of atonic uterus, may it be a vaginal delivery or a C-section? Do we have a comparison between what already exists and what is a new kid on the block. Well, everybody knows one old and one new. The old gold standard, as we consider it, is oxytocin. And now Carbetocin, on which I'm going to deliberate in a bit of a detail, these are in the list of essential medicines by the World Health Organization. Well, both have similar effects. Oxytocin works on the receptor of the smooth muscle to stimulate the uterine contraction. And we know that atony, the sooner you get the tone in place, the PPH will be well under control. Carbetocin, similarly, is a long-acting synthetic oxytocin analog, which also works by stimulating the uterus. How did this concept all start? Way back in 2012, WHO said, no, Carbetocin we are not including in the recommendation for the treatment or prevention of postpartum hemorrhage. There had been some trials. Most trials involved women who underwent cesarean section. The numbers were small, and the quality of the trials, the research was not robust. They were of different variety, and they used the intravenous route of administration, etc., etc. So there were many flaws. Then, a decade later, in 2013, the WHO was approached by Merck for Mothers, MSD for Mothers, who is now amply supporting the FOGSI flagship Manyata program. They said, we'll do a philanthropic initiative. Our broad vision is to save mothers. So let's put in some money for the research activity on Carbetocin. We need proof on the table. So Ferring Pharmaceuticals stepped in and said, we will do the preparation of this new molecule to explore the potential value of the heat-stable Carbetocin for reducing maternal deaths. So this was the combination, and the WHO convened an international panel of stakeholders who identified the need for demonstration. Is this better than that, or at least whether both are on par? So that was the concept with which this whole initiative started way back a decade ago. Remember, things do take time. So if new molecule of Carbetocin is not inferior to oxytocin, but its shelf life is long, it can just be stored about anywhere, and if it is made available in the public sector, private sector, at a low cost, because you may have something heat stable, but costing a bomb. This needs to get into every mother to save lives. So unless it is low cost, it is again not worth exploring, because dear friends, you'll agree that PPH and the rest is really the problem of low middle income countries, the developing countries like us. So thus began the story of comparison of the greatest advantage that Carbetocin has, that it does not require the cold chain transport. Even for COVID vaccine, when they said Sputnik vaccine, they said minus 40 degrees. So like how they keep the ice cream, that kind of a deep freeze jar you require to keep those. So that did not really, take off in our country, because the last mile of the supply is not possible. So it is obvious that whether it is for the purpose of availability of a refrigerator or availability of electricity, we cannot reach the last mile if a storage of a drug requires so many different prerequisites. That's a complete no-no. So the recognition of the importance of having a heat-stable molecule, which does not require any fancy cold chain storage, etc., if it is similar in its effectiveness to the time-tested oxytocin and do no harm, is our first motto. So if it has less adverse effects, then why not explore and compare how Carbetocin, the new kid on the block, performs when compared to the oxytocin. Is this really true? Is the cold chain such a big issue? So you would see here that when they did a massive survey across 64 countries, it says 22% of the facilities had no refrigerator. That is point number one. But even those who had refrigerator, as I told you, the issues with the maintenance of cold chain continuously without the electricity, etc. And only 1 in 4 healthcare staff are trained to maintain the cold chain and distribution. It is very, very obvious. We as Manyata trainers know that only after the training, one key change that has occurred in the staff nurses, Mitra, Jayam, Preeti, all are here, they will vouch for this fact that the staff nurses now quickly bring in the oxytocin from the refrigerator to the delivery table just around the time of full dilatation, because they know we need it for active management of third stage of labor. Years ago, PATH did a study where they checked in the pharmacies how they stored the oxytocin. Even the pharmacists did not know it had to be kept in the fridge, and the packets were just rolled out, and everybody started blaming that this oxytocin is not good enough because it's not having a good control on the postpartum hemorrhage. So the champions got together to do the champion trial, the largest clinical trial for the PPH prevention. Remember that we only wanted to prove whether at least both are on par, so that the huge advantage that we recognize of the heat stability and no need of a cold chain storage, that was a key point. If we get something at least good enough for that without any harm, then we are okay with it. So the primary outcome is whether it will contain the blood loss within 500 ml. So that was the key point. And the effectiveness and safety needed to be compared. So as large as 30,000 women from 10 countries, including Argentina, Egypt, India, Kenya, Nigeria, Singapore, South Africa, Thailand, Uganda, and UK inclusive, they recruited the women into the champion trial. And the primary outcome was, will it limit the blood loss to less than 500, thereby prevention of PPH? Now, if the bleeding is not controlled, first of all, you've given something, either oxytocin or carbetocin. Do you need to just push in additional uterotonics, which will add to the cost? So this was the first concept, and they recognized both carbetocin and oxytocin fare very well on this, 14.5% to 14.4. Very, very little difference. With the confidentiality interval, the researchers would know that this speaks and it's consistent with non-inferiority at the pre-specified margin. The amount of bleeding and the need for additional uterotonics, I have already told you, is less or on par. But if the patient has at least one obvious risk factor for PPH, then how does carbetocin compare with oxytocin? You would see here that more than 500 ml blood loss, or the estimated blood loss being comparable, carbetocin, in fact, if already the patient has a risk factor, carbetocin performs a bit better than oxytocin. The secondary of the outcomes was, of course, related to adverse effects, but there was another sub-outcome in the primary. So the blood loss of at least 1000 ml, if it crosses 500 also, whether it's limits within the 1000 ml, that was the next part of the study, and they did not get very significant difference either with carbetocin or oxytocin for the extra volume of bleeding saved. So primarily, if it is preventing the blood loss for within 500 ml, they said both are on par and ready to go. So the adverse effects also, at the 5% confidence interval, there were no significant differences. They also compared the adverse effects with misoprostol plus oxytocin, because sometimes you've given oxytocin, you still require misoprostol. We tell all the staff to keep the required dose of misoprostol in the box for tackling the PPH. So if oxytocin has not prevented, active management of labor has not prevented the PPH, go ahead and add misoprostol. So compared to this, when they compared with oxytocin, the carbetocin, the adverse effects were significantly less, because we also know that addition of misoprostol brings with it the control of bleeding, but also its own adverse effect. So more and more studies were encouraged to do in various parts of the world, and similar more or less similar effectiveness regarding the prevention of PPH. So they blinded it. People didn't know whether they were using oxytocin or carbetocin, but the results were on par. And in the systematic review of economic evaluations, carbetocin was more effective in the prevention of PPH because, again, to invest on the fridge and the electricity, etc., it is eliminated. That's the first line of your cost saving. And the secondly, the training aspect of it, the emergency care, which can be reached to any nook and corner. Even in the ambulance, when the patient is being transported, we can, or transferred to a higher center, we can give the carbetocin because it does not require very specific cold storage. Clinical evidence of carbetocin for C-section and vaginal deliveries. Does it perform the same? Now the randomized control trials and the meta-analysis on all of these, because by then many centers in the world started working on this. So the main outcomes that were evaluated was, do you need to use additional uterotonics? Between 500 to 1000 ml, which performs better? How much more bleeding you can save by the use of either of these? How many patients underwent blood transfusion? The side effects and effects on blood pressure, the drop in the hemoglobin, the mean blood loss, the need for uterine massage, all of these sub-factors were evaluated. And for C-section deliveries, the carbetocin was found to be more effective in 7 of the primary studies. And many centers took in the studies, the RCTs, as well as the non-randomized studies, significantly less hemoglobin drops, less additional uterotonic use, and significantly less PPH incidence. So all of these studies concluded that carbetocin is similarly effective or slightly more effective than oxytocin in preventing the PPH, especially for the C-section deliveries. It's also considered more cost-effective. When you analyze the health economics, then carbetocin use is definitely cost saving, and this is an important point for policy making. The effectiveness and cost effectiveness both taken into consideration. So overall, repeatedly, again and again and again, everybody talked about the non-inferiority. So the final conclusions of all of these, because when you introduce anything new in the WHO list or anything new in your practice, you're changing the recommendations, you're changing the protocols. So the final conclusions were carbetocin appears to be more effective than a continual infusion of oxytocin and had a similar safety profile. And the in comparison to ergot preparation, it has a similar duration of action, and carbetocin needs to be more explored. It has a potential to become the drug of choice in preventing postpartum hemorrhage due to atony. And now, after so many years, the WHO has added this into the WHO list of essential medicines. Heat-stable carbetocin is now figuring on the list of WHO essential medicines. And this is the way the recommendation goes. Uterotonics that could be used are oxytocin, carbetocin, misoprostol, ergometrin or methylergometrin, oxytocin and ergometrin, fixed dose combinations which are available in some countries. So these are as it appears in the WHO recommendations. That is the positioning of carbetocin. 2018, the Canadian guideline included, remember I told you that if the patient already has one obvious risk factor for PPH, then carbetocin does perform better. So 2018, the Canadian guidelines say twins, polyhydramnios, any such issue you notice, the carbetocin should be the first choice rather than other uterotonics. 2018, the German guidelines also included it in their guidelines, considering it as a first line of treatment. So, dear friends, watch this space. Carbetocin is currently registered in more than 80 countries worldwide for the purpose of prevention of PPH due to uterine atony following cesarean section, because that's something which we are very sure. Ferring Pharma is now seeking registrations for the heat-stable carbetocin for prevention of PPH of all births, cesarean or vaginal. Once approved, the heat-stable formulation will be available to the public at large at a reasonable cost so that it will reach the last mile. So in the backdrop of the International Women's Day, I would like to say that the theme this time is to break the bias. So don't make any assumptions. Get the data on the table, experience for yourself the ease of use and the efficacy and safety, break the bias and reach safe, quality-driven, dignified, respectful care to each and every girl, each and every woman. That is the wholesome message that we as FOGSI leaders would like to give everybody on this forum and beyond. Thank you very much, Ragini, Kiranmai, Krishna, and all the rest of the team who has made this possible and making me a part of this lovely event. Thank you. Namaste.
Thank you. Thank you very much, Dr. Hema.
Ragini ma'am,
To you. I think we had really a very good look into how Carbetocin was done. Dr. Ragini, your comments, please.
Pratima ji, namaste.
Thank you so much. It is always mesmerizing to listen Dr. Hema. The message which she has given, that bias. So we should not be biased what is going on. We have to change ourselves in the time, and respectful maternal care is really we have to inculcate, because at the delivery time, the way we treat our patient, specifically in the government sector, it is really, really pathetic. We should change, and PPH is really with the Carbetocin, we are going to have a good life and sleep easily. So change with the time is must. And I think we will little late also. I will not discuss if any question. Can we take any question?
Not right now, I think. Any questions, please put them in the chat box. The faculty would be, very happy to answer you. Please put them in the chat box. Thank you so much, Dr. Ragini. We'll wait for the good day when, as Hema rightly said, we'll have a Carbetocin, which is very cheap and available in the public as well as not only the private sector. Thank you so much. We have a small change of program. I would like to now invite Dr. Mrityunjay Bellad. So, Dr. Mrityunjay Bellad is the president of KASOGA 2018 to 19. He is a professor and senior consultant at Kahas Jain Medical College, Belgavi, Karnataka. He has got his MS Signature International Award for phenomenal leadership and excellent academic performance in 2020, Newton Baba Award for Cradle Trial Team, MRC London and DBT India 2017 to 18, fellowship from University of Illinois, Chicago, Global Network Scholar from NICHD USA, fellowship from ICOG, Best Teacher Award, Scientist Award, 75 publications, 12 chapters, and a Google Scholar with a H index of 17 and Scopus of 13. It's a pleasure having you join us, Dr. Mrityunjay Bellad. I think we have missed the A&S, the applying of the compression sutures in the hemostasis we had before this inaugural session. And I am sure Dr. Mrityunjay has gone to put some sutures, and now he's back to talk to us about A&S, apply compression sutures. Over to you, Dr. Mrityunjay.
Yeah. Thank you, madam, for that elaborate introduction. Hema, it was as usual wonderful. I just wanted to tell something about before Hema's talk. I want to conclude. We are using Hema in our hospital, even paid side on 480 rupees or 460 rupees. It's giving a wonderful result. You are saving that 480 rupees by IV fluids, infusion, hypotension related complications. So Carbetocin is a wonderful drug, and we are using regularly.
And the first ever Carbetocin injection in the country was given at Dr. Bellad's center, and we were a witness to it. So it was a very memorable experience. Yeah.
Thank you. Thank you. And can I share my screen?
Yes.
Okay. I'll minimize it. Okay. Good evening. Thank you, Kiranmai, and all the FOGSI team and organizers of this and chairpersons. It's indeed a proud moment.
Yeah, yes.
Yeah, it's indeed a proud privilege for me to address at this August gathering. I'd like to share. Most of the things are covered, but I want to rush a few of these. But mainly, I would like to show the videos. The 3 videos actually we will be sharing. Out of that, in 2 videos, I'll be sharing 3 procedures. One is the Bilinch, another is the Hemans, Along with that, Mahesh Gupta stitch, which is a combination of Hemans and the uterine artery ligation. Is that acceptable, Kiranmai?
Sir, it's a pleasure to hear you. You are an authority on PPH. Please,
Yeah.
sir, please go ahead. It will be our absolute pleasure. Yes.
Thank you. I bring greetings to you from my prestigious institute, KLE Academy of Higher Education and Research, and Department of Obstetrics and Gynecology, KLE Hospital and Jain Medical College, Belgavi. You know that the sequential actions for patients with postpartum hemorrhage: identify the cause, palpate the abdomen, measures for hypovolemia must be ready. The oxytocin, as just now Hema has told, carbetocin, methazine, and other misoprostols, all medical line of management. If no response, prepare for surgical treatment. And what is important is further management. It is time interval from onset to PPH and death is 2 hours. But 2 hours may be too late, because by then patient may go into irreversible shock. Hence, diagnosis, referral, and management must be done. And management in the hospital must be done on time to save life. At periphery, arrangements must be made to transfer with a good hemodynamic condition. So what is transition phase? Is transition period is from the periphery to the referral hospital, and in the referral hospital itself, from decision to actual surgical intervention. So the purpose of this in transition period management is maintain the hemodynamics so that vital organ blood supply is maintained. These are the procedures which are done to maintain the hemodynamics, and these are the other procedures which you have gone through, and also uterine packing. And there is another procedure which is now the Samarth Ram and Panikar who have developed on suction cannulas. That will cause the compression from within. So I'll not be addressing those. I'll be addressing on the surgical, that mainly the conservative surgeries. You all know this. This is how the B-Lynch procedure is done. Because I'm showing the video, I will be rushing on this. And this is how it comes, from front to back and back to front, how it comes. And then again, we go back on this. And this is how the uterus appears. This is our own procedure which was done. And I'll show that video, which had a septum and the placenta was attached to the septum. So these are the Cho stitches that we put that selectively. And then this is the Heyman's procedure. Another important point I would like to bring is the hysterotomy incision. If it is closed, even the B-Lynch, when you you take the stitch, but close the incision and then you apply. Probably the contraction and joining of the musculature is very essential to cause the tonic contraction of the uterus. And this is the progressive devascularization, the uterines upper and lower, and then you ligate at this the anastomotic site between the ovarian vessel and the uterine vessels. And next is the internal iliac artery. That video also is there. If there is a time, I'll try to show, because Kiran May has strictly told 10 minutes time. These are the divisions of the the branches of the internal iliac arteries. So all I am not going, and these are the collateral circulations, how it happens. The iliolumbar with lumbar, and then superior with inferior hemorrhoidal, middle and lateral sacral vessels. So this is how after ligation, it forms arterial system to venous system. And these are some of the complications if you are not careful. That one thing one must be, and that it is without any doubt, after internal iliac ligation, no pregnancy related complication, including FGR, is not noted. And this also was covered by Dr. Niranjan, that the selective arterial embolization. And this is the internal iliac video. I'll not go now. I'll go to the next one. I just want to show you this. I'll be a little fast on this. This is the septum. The placenta was attached. The first step what we do is to identify whether our suture works or not. So what is the next step? The first thing is we would like to show that the compression works or no. See this. Actually, B-Lynch demonstrated frog's position, and after this compression, the bleeding should not be seen vaginally. So what we did here is we demonstrated that compression at that point should stop the bleeding. And next step is on the lower edge, you take about 3 centimeters. And this, once you take a bite at that point, then you have entered into the upper point here, which will be 4 centimeters, because as the uterus goes upwards, it will widen. So 3 centimeters at the lower edge, 4 centimeter at the upper edge, you come out. And modification here, B-Lynch directly entered from posterior aspect into the cavity, but we modified it because we are using the Vicryl. He used the catgut, so that is why, which is relatively faster absorbed than Vicryl. So we use this technique, and then we went on the posterior aspect, and then we came out on this. And you all know these procedures, but I am a little running on this. So you know that you go posteriorly and then come. This is what was the originally demonstrated by B-Lynch. So what we did is we took these small bites on the uterus, at the anterior wall, at the fundus, and at the posterior wall, and inside at the level and above the uterosacral ligament. So you now know that you can avoid the tube. That's the demonstration which we are showing here. And I will go on the posterior aspect now. So we have pulled it on the posterior side. We are going into the cavity from front to back. After Kiran May told, I recorded the Mahesh Gupta stitch, and that video also we are showing. And thanks to my postgraduates who could be of help at that time. So we came into the cavity, and now we are entering from cavity to posterior back. Actually, initially we used the curved 1 number Vicryl needle only, straightening it and coming. For B-Lynch it is okay, but for Hemans, this needle sometimes, you feel very short. So that is the one important thing. And next we took this way to the front. So we came on the opposite side, on the front side now. See distance to avoid fallopian tube. So now we have taken one more bite on the anterior side. We are entering from anterior to inside the cavity. Now on the upper side. So we can see that needle has gone into this. And after that, we take the suture and enter the cavity. Next, we take from the lower edge at the same point where it is. So most importantly, this you need to tie once you close the hysterectomy incision, because otherwise this will cause you contraction problem. So we should complete this, and then after this suture it is tied, and this is how the uterus looks. You can see there, and there is no chance of bowel entering into these loops, which after the involution Vicryl may remain like this. This is how it is done as a B-Lynch procedure. Most importantly, we should also note that there is a recent publication in our Jogi journal on one person has reported that the uterine necrosis following the modified B-Lynch procedures. So we should be very careful to also keep a watch post-operatively. So after this, let me go on the next slide. This, if there is a time, I can rush it to internal iliac. If Kiran Mai, can I go ahead?
2 minutes, sir, please. Go
Okay.
ahead, sir. Thank you.
Yeah. So this is the internal iliac. We do that anterior approach. That is, you take an incision between the round ligament and the fallopian tube. This is a fallopian tube, and this is a round ligament, and make an incision in that peritoneum. So you will enter directly into retroperitoneal area. You can make out there. And once this is lifted, this is a round ligament, and this is a fallopian tube. So you make an incision here. All of the procedures I do with the cautery. So I cut here with the cautery. So once you are entered there, you can make out there. Sorry. So see this. You can make out there the V of the external iliac, internal iliac. This is on the right side. The ureter is on the right side here. with the peritoneal fold. And this is the extrailiac and this is the intrailiac. So you can make out very clearly. We are using the mixture, and as far as possible, about 5 centimeters away from the division you should go, because this will help in 2 ways. Number one, immediately posterior division is taken off, but the distance, if you go away from the division, what happens is extrailiac vein, which is closer to the intrailiac artery, moves away. So that is why you should ligate about 4 centimeters. And this is how we took that. Mixture is used, and then the thread is passed. You don't have to cut. You can just ligate doubly if you want to be sure. Otherwise, single ligature is also good enough. But we have also seen subsequently in one of the cases what happened to these ligatures. We saw that it had spontaneously recanalized. So I was happy to see that, if you ligate twice, probably it may not be. But see that ureter is seen on this side, and this is the intrailiac artery, and then this is the extrailiac artery. So very clear. Most of the branches also are leaving from there, so that you will not cause much damage to the pelvic blood supply. So this is the clear intrailiac artery ligation. And then I have one more. If there is a time, Mahesh Gupta stitch I can show. Madam, is that okay?
Sir, actually the time is up, but Krishna ma'am, I think.
Yeah, I think we have other speakers also waiting. We are running late by half an hour, I think. Can we have a quick 1-minute video, Dr. Bellad?
Yes, sir. Yes.
Sure. I'll show it. I'll show it. Can you able to see this video?
No, sir.
No.
No? 1 second. 1 second. Pause. Minimize. Share screen.
Your old screen is being seen. With
1 second, man. I'll do that. I'll do that.
Yeah.
Where is it? So, I have to keep that paused. But it should not be. Verena. You cannot see, right?
No, sir.
The whole screen is coming out.
Can you see now?
No. You have to share your screen again. It's completely gone. Your screen has completely gone. Please share the screen again and try.
1 second. Only music is coming. Illi pause ಮಾಡಿ. 1 second, madam. I didn't link to that presentation, so
maybe you can close the presentation and open this video separately and share screen.
Yeah, I have done that. Only I have closed the presentation. I'm trying to enter. Just a minute, madam. She's there already. 1 second. One second, madam. I'll now share this video. Can you now able to see that?
Yes.
I'll just move a little fast. Actually, what this Mahesh Gupta sir did was, he took, the same sites where either Hemans or Bilin you take the bites, you directly enter. It is a double the sutured structure. At one end, the needle is attached. On the other side, the curved needle is attached. I will show you that. So now we are entering from anterior to posterior. So we are coming on the posterior side. One side only I will show you, madam, so that the other side same thing is done. See, now it is seen, the directly straight needle is seen there, which is coming up there. The needle is here. So it has a one end, the suture end is there. Other side, you on that you have got the needle, curved needle. The purpose is that see, this is how it is entered. And the curved needle comes back for below the broad ligament avascular area. See, we have entered now. And it has two ends. Not done correct. See that this has a two ends. One end has got the curved video. So that is ligated to show that the uterine artery is ligated, and this, it causes compression of the uterus. So you have in one go, you have got both the compression suture as well as uterine artery ligation. Unfortunately, there is some network issue. This video completely, it is not playing there. So I hope I have done justice. Because I can share with you, Kiranmai, sometimes this video. You can please, you can put it in the group also. Thank you so much. Thank you,
sir. Thank you so much, Dr. Bellat, for your very interesting videos that we could see. Shall we move on to the next session?
Yeah. Thank you so much.
Thank you, Bellat sir. Though late, we had the advantage of having you and your expertise. Thank you very much.
Thank you so much.
We would now be moving on to Dr. Poonam Shivkumar Verma. She is going to talk to us about PPH care bundles. And can we have Dr. Pratima Mittal introducing Dr. Poonam? I would like to first introduce Dr. Pratima Mittal. Can we have her CV, please?
Okay, Kiran. Okay. I think everybody knows it that I was working.
Yeah, we know that you have been the Vice President of FOGSI 2018 and now are the ex-professor and HOD of VMMC in Safdarjung Hospital. Thank you so much for joining us, Dr. Pratima.
Yeah, thank you. Thank you, Dr. Kiranmai, and thank you, Dr. Shanta Kumari, for, making this program, Quest, such an important program, And I would just like to introduce Dr. Poonam Shivkumar. Can I have her CV? Hello? Hello?
Venkat,
can we have Dr. Poonam's CV?
Poonam's CV, yeah.
We all know Dr. Poonam Verma is the professor and head at the Department of Obs and Gynae at the MGMIS Wardha, and it's a very prestigious institute which is doing a very good work, and they are they have got an ideal MCH block set in, and Dr. Poonam is really doing a wonderful job, and they have done this study on PPH bundle, and I think she will be really doing justice, and on top of everything, she's a wonderful human being, very good in academics, and she's a good friend. So I invite Dr. Poonam Shivkumar to deliberate on PPH bundle, which now everybody, every medical college, every private institution should be following in, and all the intricate details should be taken into account so that no mother dies because of PPH. So Dr. Poonam Kumar.
Thank you, ma'am. Thank you for your kind introduction. It's such a pleasure to see all of you here. And I would like, at this point of time, I would like to thank all the stalwarts of FOGSI to invite me, and also specifically to Dr. Kiranmai for giving me this opportunity. I'll just share my screen. Is it visible?
Dr. Poonam, it is visible, but you have to make it full screen.
Yes. Is it okay now, ma'am?
screen?
Full screen?
No, it is just showing the, only your slides and the one slide. It's not full screen.
So I have made it full screen and I can see here full screen. Is it moving?
No. I think you have to share again.
Share screen. Now?
Yeah, now it's okay.
So very good evening to all of you. Very quickly, today what I am going to tell you is about what do you understand by PPH emergency care using the bundle approach. So what are these bundles? So I bring greetings from Mahatma Gandhi Institute of Medical Sciences, an institute which yet believes in ethics and service for the community. My objectives today are that I just want to tell you what these bundle approaches are. What are the two major bundles which are being used universally? What are the clinical and non-clinical components? And especially in clinical components, what is the use of ESM, UBT, and NASG? And then in these non-clinical components, how quality of PPH management can be changed. So I am not going into the details because since afternoon we've been discussing about it. But one thing what I would like to add is that the clinical definition of postpartum hemorrhage still remains a choice when we talk of our particular women. And 4Ts again remain the major etiological factor where we all know atonic PPH leads. Coming on to my particular presentation, what are these bundles? So basically, these bundles are comprehensive approach where, all the evidences have put in together and then you develop a strategy to deal with some important cause, which is a matter of concern and which works in all healthcare settings. So it is not limited only for medical colleges, but also for the PHCs. And it is for all income countries. It is for all areas, whether urban, semi-urban, or rural. It is a universal approach to reduce the case morbidity and fatality, and overall it reduces maternal near misses and maternal mortality. So when we go into the literature, there are several bundles which people say are bundles, and they have been used. And since morning, we've been deliberating on every small step of the bundle, which I would say was probably the best kind of webinar we have seen ever. The two bundles which we all should know, one is emotive bundle and another is PPH EMC bundle. So when we talk about emotive trial, which is a very recent trial and yet these studies are going on, it's a multi-country parallel cluster randomized trial with baseline control phase along with mixed methods and health economic evaluation to evaluate the implementation of early detection and use of the WHO motive, which is the first response treatment bundle of PPH on clinical and then implementation and resources which are used for its outcome. So emotive trial or emotive PPH bundle is the one which is being used. So what do you understand by this emotive intervention? So there are three things we need to know. The first strategy they talk about is early detection of PPH. And friends, we all know that detection of PPH has been a problem since ages. And we have been trying to measure the amount of blood loss, and we have literally failed number of times. And so we have come up with a mixed variety where you look for clinical, you look for the drapes in which it is there, and then you see how many pads and swabs and how much it is saved. So you do get approximate idea, but then you have to add additional in that because there is quite a bit which is lost. The first response bundle is called motive, which is based on uterine massage, oxytocin, tranexamic acid, IV fluid, and examination and escalation. And then after you have done this implementation, You focus on simulation-based training for the resource persons who are there or for the trainees who are there. Then you do peer-assisted learning. Local emotive champions should be there, or there should be master training where you have some master trainers who can train others. There should be a lot of mechanism for providing the feedback so as we can, change the strategies, calibrated drapes, and then of course emergency kits. And if you look into all this, this is nothing, everything we all know, everything we have been doing. It's just that we are putting it together and making it as a bundle. So when we talk about this particular bundle, you will see that in BMC, this has already come up. And now what is happening is that people are, using these small parts and doing it at their facilities, all put together. Very soon we are going to get the results of this emotive bundle, especially when we talk in terms of lower settings. So we are still waiting for the results to come. The next bundle which I am going to talk to you is a bundle which is actually running like a fire, not only nationally but internationally as well. This particular bundle, the credit goes to MGH, Massachusetts General Hospital, where Dr. Thomas Burke and his team, along with FIGO and FOGSI, who are doing the major initiatives or who have taken the major initiatives to propagate this bundle. PPH emergency bundle has got two components, clinical and non-clinical, and the bundle has a package, which is one training package and another implementation package. And this training package is also online, which comes by the name of Thinkific module. So when we talk about clinical bundles, friends, we are talking about a very small card. This is a very small card, I would say, which if given in the lower settings also, it just takes care of the initial or first response of the bleeding patient, and the patient is sent or referred to you and she's alive. So when we talk about when we talk about this bundle, the first thing you see here is active management of third stage of labor. And when we say active management of third stage of labor, we all know that we're talking about intramuscular 10 units IM oxytocin. We're talking about controlled contraction and uterine massage. There have been a lot of questions about it. People have criticized it, but yet it remains one of the major preventive mechanisms for preventing PPH. The second part of this particular clinical bundle is that you call for help, and you can have anything. In our setting, we have just put a emergency bell which has such a huge buzzer that the ring goes up till the second or third floor. So you can do any of it, but it's very important that in case of PPH, you need people collecting, and immediately you start triaging and ABCDE. Now we are following ABCDE, airway, breathing, circulation, disability, and evaluation of that particular person. So this is ABCDE. Now, once you have done that, you go on to the first response, which is nothing but massage, as said in motive, IV fluids. Now, here I would like to tell you that whiteboard cannulas are put in, but we always give crystalloids. There was a time when we all were using AMTSL, but it was seen that when you have to give blood, AMTSL had huge reactions. So crystalloids are to be given. And the concept of giving 1 liter or 2 liter fluid immediately is no more there. You have to give 300 ml, then 300 ml, and try to get the blood as early as possible to prevent dilutional coagulopathy, because of which the liver can die. And then you go on to protonic medications, where oxytocin, misoprost is there, carbetocin is coming up in a big way. But we do have little restriction for methylergometrin and prostaglandin F2 alpha. Tranexamic acid, women trial, all of us know within 3 hours, 1 gram IV, and after 30 minutes, we can use another IV. There is also something called first response supportive measure. So while you are giving all those, you have to see these things, empty the bladder, check for the tears and prepare it if it is there, because mixed variety can be there, and then empty the uterus. by massaging it. Unless you have seen that the clots are stuck, please do not put your hand inside and take out the blood clot. Any time you try and massage removes the blood clots, so you prevent the women from having further endometritis and myometritis. Then we come on to the response to the refractory PPH. Now the PPH does not stop in spite of giving all medical management. Then we go for compression manuals, where we talk about bimanual and abdominal aortic compression. And then we go for uterine balloon tamponade and non-pneumatic anti-shock garment. I'll take a minute to tell you about these two. Uterine balloon tamponade has come up in a very big way. You use whichever uterine balloon tamponade you want, but we have seen, the 11-12 medical colleges have seen that ESM UBT has made a difference. It is little different than your Foley's catheter, condom catheter. It is much cheaper than your Bakary balloon. So for these settings where you do not have very rich people, you can use this UBT, and Pregna International is making this UBT. We all can get it from there. It's much cheaper, 900 rupees only. Anti-shock garments are the garments which are used not for, taking care of the cause of PPH, but pushing the whole blood onto the vital organs. So whenever you refer these patients with NASG on, you will realize that the woman comes alive to you, and you can take her immediately to OT or to a high dependency unit, where you can either put a balloon or you can save this woman by surgery. So this is what is your response to refractory PPH bundle. And then there are supportive measures again here, that immediately getting the blood transfusion, transfer the women at higher center at right time with all referral protocols. So those kind of teachings are also given. And then if nothing is working, please go ahead with surgical management. These are some additional clinical practices which have been mentioned behind. We're not going to go in those details. But this PPH emergency checklist is going to make a difference, because many a times in hurry and when you are in a mess, you tend to forget certain things. And you will be surprised that even at our level, number of times we've forgotten to give tranexamic acid, which we shouldn't have. So these emergency checklists, if somebody is bleeding, you do the full justice to the management of PPH. Very quickly, I'll just talk about non-clinical component of PPH bundle, where leadership is one of the major story, because unless you have a leader, you cannot probably go for this kind of bundle. Non-clinical bundles are the or these are the components which are very, very important, because even if you have a facility with all sorts of equipments, with all sort of expertise, your facility is extremely ready, but unless this woman reaches to you alive, probably you won't be able to do anything. And there comes the role of non-clinical part of the bundle. So if we look into the non-clinical part of the bundle, one, of course, you giving clinical care, but unless you have facility readiness, unless you have network integration, unless you have teamwork and communication, and you have data which continuously does quality improvement, probably you won't be able to save the patient. So teamwork and communication is very, very important. The team has to be created, and it should be an emergency response team where number of people should be there, not only obstetrician and gynecologist, but also anesthesiologist or critical care consultant, the medicine person, and everything should be displayed. So the right diagnosis should be made at right time, and there are no delays. And the team should also know how to divide into in charge, assistant, supplier, and informer. So there's no chaos and everyone knows their responsibility. And we have been seeing over the years how scenarios have changed when we have been doing repeated drills and ensuring that our team knows what they have to do exactly. These are certain things which one have to follow. The debriefing after the session is over or the scenario is over, the women has survived. All of us should sit together and debrief where were we wrong and where were we right. And if we were wrong, what needs to be done next time? S-bar, we all know: situation, background, analysis, and then recommendations. Closed loop communication is, let's say I am giving oxytocin. So I will tell my in charge, I have given 10 units, I am oxytocin. So he knows that this has been given. I have given Tranexamic acid. Many things, by eye contact, and this thing can happen with closed loop communication, so that even if the woman is in her consciousness, she doesn't hear anything, which makes her even worse. And huddles and board rounds are the ones where the whole team comes together, takes rounds repeatedly, and every person in that emergency response team knows what they are supposed to do and how quickly they have to see the patient in which hour or time. So these are few questions you ask during debriefing, and you get the answers. Communication is something which is very important, and this has been lacking, and that's why women have been dying. There's no communication from the referral facility to referring facility to referral facility. There's no communication to the critical care consultants and so on. So you will see that at every level, intra-institutional, inter-institution, calling for help, so on and so forth, there are a number of places where communication is mandatory. And in this era of medico-legal issues, patient and relatives have to be communicated properly. The next very important thing is facility readiness. And when we talk about facility readiness, these are number of things you need to see. So it's not only infrastructure, it is also that your team is ready. It is also that your team is trained. It is also that the drug supplies, equipment, everything is there. And in this, most important is that PPH kit is available and it is complete and it is repeatedly replaced. There are a lot of barriers which one see, but these barriers are all which can be taken care of. The staff problem is universal. Accountability is universal, but a good leader can look into all these problems. And then when we come on to these checklists, you will see that facilities have these kind of checklists, which will help you to see whether your facilities are ready or not. And then last but not the least is network integration. So it's very important that we have helplines. We consider nearby facilities as one team. There's bi or multi-directional communication, and there is improved reference. So these are 6 T's which are to be seen when we talk in terms of network integration. In phase 1, we should do team building, training them and talking to them and understanding their problem. And in phase 2, we talk more about transferring referrals, tracking. Once referral is there, then we also have to see what happened to this particular patient. It's not that just you shift the patient and everything. And then thanking means, it is a bilateral communication. The loop is completed. So that is the things. These are all checklists. I'll just go very quickly. Quality of care has to be improved, and we can only do that when we reflect back and then we plan forward. And this planning forward can be done by data measurements and monitoring. And this data can be used to know how things have to be done. So we have to dig into data. Very quickly, I'll just share that this has been an experience of different countries. And this man is responsible for helping all over the countries, especially low-income countries. So Cali has improved their survival of women, and you will be surprised that Dr. Maria Fernanda runs a 100-bedded ICU in Cali, Colombia, which is a middle-income country. And over the years, she has now 0 PPH deaths. Similarly, we have also done study in 11-12 medical colleges with the FIGO initiative. And I would like to tell you that we have done several workshops. We have created WhatsApp group where we have very interesting stories of the women who were nearly dead with pulseless and BP-less, and we have saved them using UBT and NASG. We have done system integration in 28 PSC, 9 CHC district hospital, and we have gone to these facilities to do their readiness. So you can see the medical colleges where facility readiness has been done. where teamwork and communication has been taught to the periphery. Quality improvements have been done regularly by creating checklists, data monitoring protocols, and then we have done advocacy and branding to all these areas, and Government of India is happy to do it in different states. So you will be very surprised that we have done all walkathons and everything to advocate it. We have seen lot of lessons. We have learned lot of lessons and have overcome many obstacles. And now I am telling you that in this 11 medical colleges for 1 year and 9 months, we had not a single PPH death. 52% cases came with NASG on. 46 were referred with UPT. Helpline calls have helped us so much. So it's been really a wonderful experience to have this PPH EMC bundle in place. Now it's going on in Uttar Pradesh, where Dr. Preeti has taken over as the chair of the Safe Motherhood Committee. Lot of phases are going on. Now we have completed all phase 3 and implementation is going on. And now this is moving towards the CEFOC countries as well. So friends, I would suggest that my conclusion would be, let us all put head together to identify each component which helps in prevention and management of PPH. Let us bundle it together, see the research literature, and also we can create the evidences, monitor them, evaluate them, and identify what are the best practices for our women, because our women are our women and they should not be used as guinea pigs. And we should do the advocacy and create national as well as global guidelines wherever we find that these bundles are working. Thank you so much for your patient hearing.
Thank you. Thank you, ma'am.
Thank you. Thank you very much, Dr. Poonam, for this very much needed and exhaustive, what we say, an update about where the care bundles can take us. Can Dr. Pratima give her remarks?
Yeah, thank you. Thank you, Poonam. It's an excellent talk, clear, crisp, comprehensive, giving all, small details in good perspective. And secondly, but you have focused on the bundle approach, which very clearly says that we have to be prepared for readiness, response, recognition, as well as review or referral. So all these things have to be taken into account. And the most important thing is the use of checklist, which has made our work so much better quality wise. We have really improved by implementing these checklists. And the main purpose of this bundle approach, which I could understand, is the universal application in all the institution without any judgment about the rich or poor country, all the countries. And besides that, it is the internalization of the approach. It is, if you understand, if you internalize how it has to be done every time without even thinking, if you keep on doing such things, so that will, just jaise hum ABCD yaad karte hain na. So I think this is the way which we can remember how to manage a case of PPH, how to prevent a case of PPH. Then I think we will not make any mistake, and definitely teamwork is going to be really, really helpful. So
thank you so much.
We really feel that with this approach, we should be having no PPH death, and our aim should be 0 PPH death. Thank you.
And extend it to all the medical colleges in the country, at least as a beginning, and then to all the private setups.
Yes.
Thank you. Thank you very much, Dr. Pratima and Dr. Poonam. We now move on to the next important talk by Dr. Atul Ganatra. And for that, to chair the session, I would like to invite Dr. Ashwath Kumar. Dr. Ashwath, are you here?
Yes.
I'm here. The CV of Dr. Ashwath. I think even Ashwath doesn't need any introduction.
No need of CV, madam.
Him as the champion of Medha. And he is doing a wonderful job for the postgraduates of our country. And he is a County Council member of ICOG and first Care Light. Oh, great to be elected to the Governing Council member. And I know him as a very dynamic endoscopic surgeon of gynae oncology, professor in the Department of Gynecology from Jubilee Mission Medical College, Thrissur. Over to you, Dr. Ashwath, to introduce Dr. Atul Ganatra and his topic, massive obstetric hemorrhage and massive transfusion protocols. Do it right.
Good evening, everybody. First of all, I thank Shanta madam and the whole team, Krishna Kumari madam, Kiran madam, and the whole team for inviting me to chair this session. And till now, what you were, which we don't want to happen. That was what now Adul Ganathar sir, if it happens, what to do? Massive obstetric hemorrhage and massive transfusion protocols. So to introduce, can you have the CV of Adul Ganathar sir? Adul Ganathar sir, Vice President FOGSI 2020-21, Joint Secretary of IEG, Chairperson MTP Committee, MOX, Managing Committee Member MOX, Medical Advisor Committee FPAI, Director RJ Ganathra Nursing Home and Progeny IVF Center, consulting obstetrician physicians in many hospitals, including Fortis, HMN, and Jupiter hospitals. So, and I will be it is so fortunate or happy to introduce sir, who is my friend in FOGSI. Adul Ganathra sir, it's yours. You can share your slides.
Thank you very much, Dr. Kiranmay and the entire team. I'm a little overwhelmed by the number of people and the professors that I can see here on the screen. I'm a simple practitioner practicing in a city of Mumbai. Can you see my screen?
Yes, yes, we can see your screen.
Yeah, so my job is to talk about massive hemorrhage and to talk about the massive blood transfusion protocol. Unfortunately, it's a little short of a time because I've been given 15 minutes and I may not be able to do justice. But please stop me wherever you think that my time is over, or I will stop there. Thank you very much, FOGSI, the entire team, for allowing me to make my presentation. We don't grow when things are easy. We only grow when we face challenges. And obstetrics is one situation, especially postpartum hemorrhage, is a situation when you actually get to know the nerve of the surgeon, the nerve of the consultant treating. Like Dr. Poonam very well said, it's a teamwork. It cannot be done by an individual. It's not like a lap hysterectomy that one person doing it very well. This is a teamwork. A genuine PPH can even scare a cardiac surgeon. And I keep telling my cardiac surgeon colleagues, you will never see so much blood loss. It's like a municipality tap running. This is some case many of you may have seen. A deaf and mute primary was referred to us after obstetric hysterectomy done for PPH. She was referred to us at Fortis because she was refused admission at a major BMC hospital. Now, we've had a few more cases after this. On admission, there was no pulse and blood pressure. HB was 2 grams, INR 1.9, platelet 40,000, fibrinogen 45, lactate of 12. Mind you, lactate of anything more than 2 is very serious. Dr. Pratima Mittal is here, probably an authority on PPH and shock. She was in a state of hemorrhagic shock. And Dr. Preeti also has been doing wonderful work, I think. I now call her initially I used to call her world famous in India. Now she's world famous, actually world famous. She's been going all over UNICEF and so many associations. So when we did a CT angio, first of all, the ER team of Fortis is so strong. This patient did not even have a COVID report. This is in April 2021. We had to give her about 2 liters of fluids to get her blood pressure. We actually gave her 12 PRBCs, 20 FFPs, and 24 cryoprecipitates. When we did her CT angio, because hysterectomy was already done, we could see that the ovarian artery was bleeding. There was a leak in the ovarian artery. So we went ahead and embolized it. After embolizing this ovarian artery, the consultant interventional radiologist called me and said, do I do the internal ILX? I don't think there is any necessity. I've already fired these vessels. And I told him, please go and fire everything you can. Patient anyway does not have a uterus. This patient was deaf and mute. Her husband was deaf and mute. She was in a state of shock. She was brought to us by an anesthetist. We sent her home in 3 days. Here is where the real, what can I say, communication skills, emergency skills of an ER department really works. And I'm really proud of the department I work in. Another patient, here again, central placenta previa, was sent to us with bleeding, massive bleeding. She was twins, she had twins. As you can see here, we went ahead and did a cesarean section on her. We went above the lower edge of the placenta as was seen on ultrasound. We first closed this area. She was bleeding very, very heavily. She was passing blood clots. Then we went and looked at the placenta. We could eventually remove the placenta. This is where the placenta was. We took a couple of deep interrupted sutures here. We took a couple of Cho sutures as well because the patient was in a state of shock. This is what the uterus looked like at the end of it. This patient was a patient of 2 previous cesarean. This is just about 3 weeks ago. She had an ultrasound report which said central placenta previa and she was bleeding. We took a couple of deep sutures here in the lower segment. It was an anterior placenta previa. We did an internal ligation, also maybe an overcorrection, but we also took a B-length suture. So this is something that we need to do if you have a patient who comes to you in an emergency, and that is why your staff, your colleagues have to be trained to look into these situations because we are a tertiary hospital. Sometimes we don't have time to do another ultrasound. So my job as a vice president, I thought, unfortunately, COVID took it away from us, is to teach every gynecologist how to do internal ligation. I think this is something that we must do, and I'm sure the FOGSI leaders will probably do some physical workshops. Dr. Preeti Kumar has promised me that she'll do a few. And this is something that can really shock you sometimes. Another one, P2L2 referred to us after having diagnosed placenta perforator, USG and MRI suggest 2 LSCS. Asymptomatic, blood arranged, informed consent taken. You can see here when we thought that we were opening the UV fold of peritoneum, we opened the bladder. Placenta here, we just went ahead, did a classical cesarean section, repaired the bladder and did a hysterectomy. The patient was ready for a hysterectomy. Another dentist, similar situation, placenta punctata referred to us from Dubai. Because in Dubai, they told her, please go to India, don't get it done here. She had 2 endometriotic surgeries, 1 medical management for cervical ectopic, 1 ovarian cyst and 1 medical MTP. Look at the lower segment here. You cannot go there. You just cannot go there. You have to take a classical cesarean section. For the first 15 years of my practice, I did not do a classical cesarean, but in the last 4 years, I've done about 17 of them, all of them perforator per perforator. Suddenly, we've had a huge number of patients coming to us like that. Case 3, again, G4, P1, L1, A1, 1 previous LSCS, 21 weeks pregnant, referred to us with severe bleeding. USG, she had a USG report which said perforator accreta. We didn't know, but we could see this very good line here. And this we thought that at least the bladder mucosa was not involved. First dose, Dr. Poonam was talking about, we gave her 1 gram of tranexamic acid. She settled down. 6 hours later, she was again started pouring. We took her up for an emergency hysterectomy. This is what it looked like again in the lower segment. Here, since the uterus was only 20 weeks, we removed the uterus, did the internal iliac, and then did the hysterectomy. In spite of that, the patient needed about 6 pints of blood. We did a subtotal hysterectomy. The edges were underrun, bleeding continued, put in a Bakri balloon, and removed it about 24 hours later. As you can see, this is the situation. So I could go on and on. Central placenta previa, we put a femoral balloon through the femoral artery into the internal iliac, put in a Bakri balloon after the baby came out. Over that, we thought we will suture. Once the baby came out, we deflated the internal iliac balloon, but the patient started bleeding, and as a result of which we had to put a Bakri balloon and then suture over it, and the Bakri balloon was removed 24 hours later. Another situation where we had a torsion, acute abdomen torsion of a fibroid in a patient with previous section. So basically, postpartum hemorrhage represents one of the main causes of maternal mortality worldwide, representing about 25% of deaths. The maternal mortality ranges from 15 to 43 for every 100,000. And the golden hour aims to reduce morbidity and mortality related to the delayed management. So basically, what is the golden hour? The first 20 minutes, I'd say 5 minutes. Medical treatment, fluid replacement, management of the main cause of bleeding. The 4 T's, stone, tissue, trauma, thrombin. The second 20 minutes, I still say again 5 minutes, performing mechanical maneuvers, including uterine artery tamponade with a balloon, compressive sutures, pelvic vascular sutures. If all this does not work, though it is said 20 minutes is too long a time, the patient will go into irreversible shock, especially if you don't have facility for massive blood transfusion. If you don't have the garments. Finally, The remaining 20 minutes are for non-conservative surgical techniques, which includes a hysterectomy and a damage control surgery as the final weapons to avoid maternal death. If you wait too long, the patient is going to go into DIC, and in spite of the hysterectomy, the patient is continuing to bleed. I have seen 17 to 18 patients who have been referred to me after a hysterectomy. One patient was referred to us after a hysterectomy where she had a large perinephric, a large broad ligament hematoma right up to the perinephric space. Her INR was 3. I wish I could reproduce these pictures, and I was told, do a laparotomy. Do a laparotomy and do what? Went ahead and embolized her, and she settled down. So conservative surgical management in PPH includes surgical procedures that can avoid a hysterectomy, but do not delay a hysterectomy till the patient becomes bad. The most used procedures are hemostatic sutures with referred to, ligation of pelvic vessels, and uterine compressive sutures. And the success rate will depend on the cause, the intensity, the location of bleeding, as well as the type of procedures chosen. And I would say the timing of the procedure also. Obviously, if there is a large cervical tear or a vaginal tear, these procedures are not going to work. You have to evaluate the patient thoroughly in good light. And please remember, if you have a patient who's bleeding heavily, please take her to the theater, give her general anesthesia, and then evaluate her if you have the facility, obviously. So basically, the uterine artery ligature is an excellent tool. But if you have a bleeding from the cervix of the vagina, it's very ineffective. B-Lynch, excellent. Not effective in a trauma patient. Cho sutures, very, very good in all these situations. Heyman sutures, excellent, but poor and ineffective in an upper vaginal tear. Selective lower vascular ligature, excellent in a situation if there is a cervical or a vaginal trauma. So basically, we need to divide these patients into two groups. The sagittal scheme that says S1 and S2 to find out if the patient is bleeding from S1, that is the uterine fundus, and S2, whether she's bleeding from the lower segment or the cervix or the upper part of the vagina. And your treatment plan depends upon whether she's an S1 or an S2. Patient at imminent risk of exsanguination, if the facilities are not available and open the patient, you should do what is called as a manual aortic compression. Apply direct pressure on the aorta to compress it against the vertebrae a few centimeters superior to the sacral promontory. And you could do this using Dr. Piley's forceps. And these are two places that you can do it. If you want to evaluate the patient, if you are not skilled enough to do internal ligation, before that, if you feel that the patient is deteriorating on table, if the anesthetist tells you that the BP and the pulse is dropping, and you could use this compression for as much as 1 hour. And this is Dr. Piley's training. I think this is extremely good. I bought these faucets, fortunately never had to use it, but this is something that you must keep. Balloon occlusion of the aorta, I showed you a patient, central placenta previa. We put in a balloon through the femoral artery into the iliacs. But unfortunately here, you may have to relieve that pressure after some time. And then you have to assess the bleeding. So we had to put a Buckley balloon at the end of it. A tourniquet can be applied. A simple urinary catheter like the Bonnie's clamp can be applied. A second and a third tourniquet also can be applied. These are situations where you can apply the tourniquet here and you could apply it here as well. The balloons, Dr. Poonam has already spoken to you about. Different types of balloons you get. This is a very, very interesting balloon, the Ebb complete tamponade system, where even the lower trauma, that is the vaginal area, can be kind of used pressure in the tamponade. This is how it goes in, and the cervical bleeding and the vaginal tears sometimes are very difficult to suture, it will also be occluded. This works pretty well. You can use mops. When it is indicated, the conservative treatment and efficacy for controlling the bleeding and avoiding a hysterectomy ranges from 60% to almost 100%. But the overall success rate is usually superior to 80% in most series. So basically 9 on 10 times, if you are on the right track, if you're on the right time, you will succeed if you categorize between S1 and S2. Here you can see another patient where we've taken the B-Lynch suture. The Heyman compressive suture, I don't have the time to discuss each one of them. The Cho compressive sutures, as you can see here, this is the Cho suture. You go in, make a square and come out. The Pereira compressive suture, we take multiple sutures. This is the Japanese method wherein they put in a balloon and over the balloon they take sutures, the Masubra sutures. The DB sutures here, they go around. This is very, very useful in placenta previa. As you can see here, you go in and around the lower segment of the uterus and take sutures. Or you can do stepwise devascularization of the vessels. You can start from here. First, of course, you would do the uterine artery and then the junction between the uterine and the ovarian artery. Stepwise, this is step 1, step 2, step 3, and step 4. You could go on and stepwise do devascularization. This is the stepwise ligatures. The first step to perform the distal uterine artery. Second step, the round ligament ligation. Third step, the uterovarian ligaments. Fourth step for persistent bleeding, proximal uterine artery. And the fifth step is finally the internal iliac artery. I would be a little more aggressive. I'm a great believer that this is one procedure that every gynecologist must learn. Does not take more than about 3 minutes. And this is something that has saved many, many lives for us. As you can see, this is Professor Khalid doing the procedure at a workshop which I attended many years ago. Very, very simple. The area between the tube and the round ligament has to be incised. He is using the cautery, but you can use a simple sponge and a holder. You need 4 Devers forceps. And this is how you get your plane. All you need to do is to put your finger and create a plane. Put Devers. 1 Devers faces the liver. One person, the most important person, is the person who lifts up the uterus away, and so that the ureter can be taken away. This is the second Devers, which lifts the uterus and takes the ureters away. You need a disposable suction. As you can see here, you need a disposable suction to do a little bit of blunt dissection. There you can see the ureter. That's the only structure that you need to be careful about. And that is the external iliac artery. Ureter has to be constantly in your vision. We've now done about 21 of these procedures alone. Of course, I did a couple with a few of my colleagues. Pick up the internal iliac artery. He's using an Alice forceps, but I think he's brave. I would use a Babcock. Just go from left to right. Remember, you L to R because the iliac vein is just below that. Create a plane during a cesarean section. Pass this mixture forceps, just pass the vicryl there and do not ligate it. You can see the ureter here moving just very, very close to it. Trust me, I've done about 21. Doesn't take more than about 3 minutes to one side. There is no bleeding. So this instrument, I would use a disposable suction here at this level to create the plane. And I think the procedure can be done very, very effectively. Another important point that I want you to remember is sometimes we get calls from very, very distant places that we've done obstetric hysterectomy. The patient is still bleeding. We want to refer the patient. The 2 important things that we tell them: please pack the abdomen with green towels, not mops. These green towels, massive green towels, and keep a drain inside. 6 to 7 of them. So 2 of my colleagues have referred patients to us from the periphery with the abdomen being packed with these green towels. And of course, to keep a drain inside to assess the clinical situation inside. By the time the patient came to us, all she needed was DIC correction. We corrected their DIC and removed the drain and the green towels after 48 hours. I think this is something that everybody at every level can do if the patient is bleeding excessively after a hysterectomy. Massive blood transfusion protocol is traditionally defined as transfusion of 10 units of PRBC within a 24-hour period. The goal, of course, is to limit complications and limit critical hypoperfusion, while surgical hemostasis can be achieved. Target mean arterial pressure 60 to 65, HB 7 to 9, INR less than 1.5, fibrinogen greater than 1.5 to 2, platelets more than 50, pH of 7.3. This is very, very important. Another very important thing is that every obstetrician must have a NIBP in the hospital. We buy expensive mobile phones, we buy expensive cars, but we don't have infusion pumps, we don't have NIBPs in the hospital. A simple NIBP with pulse ox, pulse and blood pressure costs only 20,000 rupees. These are patients where your every 2 minute, every 3 minute blood pressure record is extremely important. Again, the transfusion protocol are activated by a clinician in response to massive bleeding. It is activated up when you need a blood transfusion of more than 4 to 10. It has a predefined ratio of RBCs and FFPs in cryoprecipitate and platelet units. Random donor platelets in each pack. It could be either 1-1-1, that is 1 PRBC, 1 FFP, or 1 cryoprecipitate, or 2 PRBCs, 1 FFP, 1 cryoprecipitate, depending upon the clinical situation. Sorry. Practical tips: early recognition of massive blood loss. Collect sample for cross-match early, as colloids may interfere with cross-matching, mainly dextrans. Inotropes drugs should be only used in a blood loss scenario due to severe hypotension. Do not exceed recommended maximum doses of colloid. Avoid giving colloids unless there is no facility for blood, but please collect your blood before you give colloids. Also use starch-based colloid solutions in large volumes in a hemodynamically critical patient. Complications you could have as a result of massive blood transfusion: you could have alkalosis, hypocalcemia, hypothermia, hyperkalemia. These are things that you must be able to pick up. And you could have a transfusion related lung injury and a transfusion associated circulatory overload, which can occur with massive blood transfusion. So I think everybody now must have a so-called HDU, where you can at least put in a central line so you can monitor the kind of blood, or at least remember a simple method of finding out if you're overloading your patient. Take your abdominal probe, put it on the IVC. If the IVC is collapsed, the CVP is not very high. That is a very, very important trick that I've been taught by the critical care people that we have at our hospital. Finally, friends, knowing yourself in the beginning of all wisdom. It is the beginning of all wisdom. So we should know what we can do, how much we can do, when we should transfer, and how we should transfer. Thank you very much for your patient hearing.
Thank you, sir.
Thank you. Thank you very much, Dr. Atul. Impressed and fascinated by your journey on how to prevent the need for massive transfusion protocols. Thank you so much. Dr. Ashwath, your comment.
Yeah, it was as usual, Adul sir. It was an excellent talk with you. Showed so many practical videos as well as practical points. Only two things which I wanted to add is that when it's a placenta accreta or percreta, what I have felt is that after using this aortic and the common iliac clamps, many times when if you only ligate, previously we all used to ligate internal iliac only ligate internal iliac, the bleeding may not stop. So, and the skill for the juniors may not be trained of ligating internal iliac, as you correctly told, we have to develop. But when you are using this clamp, the advantage is that even if you can apply it for 1 hour, by the time you can tackle the issue. So almost the death due to or the complications due to placenta accreta percreta in Kerala after using, everybody is doing now, juniors, because they clamp the aorta. It is the limb ischemic time is more than 1 hour. So in between, if you want, just release it, again clamp it. And even you don't have to dissect that area, just identify it, just clamp it. So it is practically very easy for. Another thing, what I tell about the massive blood, maybe you would have told because of the lack of time. See, we have now rotum and TEG. See, because of all these things have come to all. I know that Fortis and all these hospitals, you will be having this. So it helps to avoid unnecessary transfusion. So sometimes you need only cryo, you give only cryo. So when you overload the patient with FFP and all, trialy and all these other complications happen, you may save the patient, but later patient may have other complications after within 24 to 48 hours. So all these facilities are now available. So if you send it for within 15 days, you get what 15 minutes you get. So you start the protocol, but within minutes you have this thing and take the transfusion medicine people in your, always it's a teamwork, as you all told, it's a teamwork. This few points, which 2 or 3 points, so many things. The PPH discussion will go on. Now itself we are late, I know. Krishna Madam will be looking at me through the window I can see. So thank you very much. Thank you for the opportunity and to be chair Adul Garatra sir, who is my very close friend. Thank you.
Yeah, we have everything. We have Sonoflot, we have Rotem, we have TEG, but I don't mention it because 95% of hospitals may not have that facility.
And it is coming up. These are the things which are coming to available slowly in more, because it's a referral. See, these type of cases cannot be managed in a first advice is that a placenta percreta accreta should not be managed in places where facilities are less. It should be managed in tertiary care with all facilities. So most of the hospitals are coming with all these things. So I just wanted to, anybody doesn't know about TEG or ROTEM can read about it. That's it.
Thank you. Thank
We
you.
are so every liver transplant unit has to have ROTEM and
I
TEG.
know.
So we've been doing even cardiac transplants now, more than 150 cardiac transplants. So, but I didn't want to kind of pressurize people that they are not capable. Yeah, we didn't want to intimidate them. I agree with you.
Somebody was putting up a note saying that there are no NASGs available with them. So I think we have still in many cases a long way to go. And I think
Dr. Krishna Kumari, we buy mobile phones worth 1 lakh rupees.
Yeah.
I think every hospital, every 5 hospitals must have one anti-shock garment and one Bakri balloon. They can split the charges.
And ma'am,
So I don't agree that
Kerala was that Kerala Society, that means Kerala Federation, bought NISD and distributed to all the needed hospitals, periphery and all.
I think we have to move on, Krishna ma'am.
Yeah,
Is
it
going
was
to.
a wonderful.
We're all
Get
mesmerized.
lost in this fascinating exchange of views. Thank you all so much for this wonderful notes. And with this, we close this session on the keynotes and move on to the next session. And for that, I would request Dr. Kiran Mai to take over and introduce the next session moderators and panel.
Yeah, we intended to be on time, but because being the Zoom platform and all the hitches and the interesting discussions and lectures going on, we did exceed some time. So without wasting much time, I would now invite another interesting panel to be moderated by our own very own Vice President, who is in charge of today's program, and Dr. Archana Verma, and also along with her we have Dr. Bharti Joshi from PGI Chandigarh. Can we quickly have a series of both Dr. Archana Verma Madam and Dr. Bharti Joshi? Yeah, Archana Verma Madam is passionate, always writes this, passionate about creating awareness on women's health. So any area which is requiring awareness, she is there, lending her voice and taking a very active role. She's now presently our own Vice President, and she was founder president of West UP chapter, organizing chairperson of so many things, and she's India book. Madam, yeah, you have so many things, and we love you. Thank you. And Dr. Bharti Joshi is from assistant professor in OB-GYN at the prestigious PGI Chandigarh. And she has many research publications coming from the Institute of PGI. And she was a COVID-19 nodal officer from the Chandigarh PGI and co-investigator for WHO ICMR projects for COVID-19. And as Archana Madam very fondly recollects, she was the joint organizing secretary of the North Zone UA FOGSI 2020, having done excellent work. Welcome you, Dr. Joshi. Let me move on to the panelists. We have an excellent array of experts as panelists. Dr. Taru Chaya, who is the secretary of Jaipur Obs and Gynae Society, director of Bansal Hospital, and she has special interest in high-risk pregnancy, menopause, and uterus conservation and infertility. Can we have the next panelists? Dr. Achla Sahai Sharma is again from a medical college, professor of GR Medical College, and she's a very dynamic secretary of Gwalior OB-GYN Society, and she's many more things. For paucity of time, I would request to move on to the next CV. Dr. Swati Rathod again is from CMC Vellore. She's a professor there, and she has a lot of affiliations and publications with special interest being maternal fetal medicine and high-risk pregnancy. Welcome you, Dr. Swati. Next. Dr. Anjali Kanhere is professor and head of department of Bhopal OB-GYN CMCH Institute, and she's also the president of Bhopal OB-GYN Society, and she's recipient of prestigious Dr. Jagdishwari Mishra Best Poster Presentation for 3 consecutive years, and many achievements and awards to her credit. Next CV. Dr. Mudita, I think we are not having Dr. Mudita Jain. She has expressed her inability to join today. And Dr. Sudesh Agarwal again is a professor and HOD from Department of OB-GYN, Sardar Patel Medical College, Bikaner, Rajasthan. Madam has again many diplomas and fellowships and 12 gold medals for academic excellence. We have, as I have told, excellent experts as panelists. Over to you, Archana madam and Dr. Joshi. The panel is on retained placenta with interesting case scenarios.
Shailaja, you did not introduce
Yeah,
Shailaja.
sorry. Can I have Dr. Shailaja's CV? Sorry about that. Dr. Shailaja is a very dear friend. She is the secretary of OB-GYN Society of Visakhapatnam, very active member of FOGSI. She's an associate professor of Andhra Medical College, Visakhapatnam, and she's a fellow of ICOG, and she's a faculty in state and national conferences with interest in practical obstetrics and high-risk pregnancy.
Okay.
Yeah. Thank you, ma'am. Thank you.
So my moderator, Dr. Bharti Joshi.
Yes, ma'am.
Yes. Hello. Good evening. And
good evening.
we two together will manage all the retained placenta cases. And so
yes, definitely, ma'am.
Please, all of us, don't sleep and be alert, because obstetric emergencies are like that only. And though it is the last session, not last session, I think after that there is also many things, because this is such a going on. How much time? I think the Bharti will manage. Bharti, please.
Given 40 minutes, we will just run through the cases. So, yes. Should I screen it?
40 minutes.
Okay,
and
40 minutes.
Time starts now.
Okay, Dr. Archana, should I share my screen?
Yeah, you please share your screen, Bharti, because
is it visible?
Yeah. So today we are there with one smart panel made especially by Bharti. All the cases are actually real, because the day I was talking to Bharti and she was busy managing a retained placenta only, and at that time Dr. Kiranmai called me, and then we were given this work of this panel. And so I just want to say that the obstetric emergency are the part of this system, and all the gynecologists, they get chance to manage it. And imagine a tired obstetrician and going back, and again all of a sudden she gets a call from her resident that a collapsed patient has come and quite late. And we always start grumbling, where was she, why she was not showing us previously and all. Next slide, please. And because one of the things is that whenever there is a retained placenta, and what retained placenta means is actually by definition clinical, when there is no placenta delivered after 30 minutes maximum, or sometimes we wait only 20 minutes for the delivery after the baby. And the causes, by the mainly 3A are very important: atonia, accreta, and absence of the AMTSL. Next slide, please. And risk factors we'll be discussing with all the panelists next. And this physiological part also, for the retained placenta is also to be kept in mind, so that we can avoid too early management or the too late management. Next slide, please. And say theoretically, this retained placenta can be a separated, but retained, unseparated, and retained placenta. And these are mainly the placenta adherent placenta because of anything. And then this pass spectrum, which is nowadays much talked about. Everybody knows we are doing too many cesareans, and sometimes not even the cesarean, so many other more important causes also as such. Then there is a placenta adherent. And then so we start all of us, we actually keep on tackling all these cases. So let me start with the first case scenario, where a 20-year primary patient received in the obstetric emergency with a history of home delivery by at home 2 hours back, and then there's a pulse rate was 124, tachycardia was there, and the BP was, the blood pressure was 90/60. She was really paler, anemia was plus, and on examination, after general examination and abdomen, the main thing was cord was seen hanging outside vagina, and bleeding was there a little more, and the placenta was inside the uterine. And so now your time starts now. Next. What could be the reason for retained placenta in this patient, Dr. Taru? Dr. Taru is a, know that she's a wonderful.
I'm audible. Thank you, Dr. Archana, for
gynecologist.
Yeah, hi, Dr. Archana. Thank you so much for a nice question. Actually, the patient is delivered home delivery by DI, and she is primary. And when the cord is hanging, that means it is the case of retained placenta. But what could be the reason for this retained placenta is more important to know. By the question, we don't know the baby, it is full-time delivery or is a little premature delivery. Number one question. Then number two is how much.
Take it as a normal 37 weeks.
30 full-time delivery. Okay. Then because it is dye handled, so we don't know, because they don't know how much medicines to put, because at times why it happens is uterus contracts or uterus has atony. Two major reasons are there for which the retention of placenta can be there. It's hourglass. When uterus contracts, below the placenta is separated and the os closes. Then placenta remains inside and it doesn't come out. Number two, maybe the dye has given more of oxytocin, or dye must have given methogen much in advance. So just after delivery, os closes. So there are very practical reasons why the retained placenta is there. Baki, another pathological reasons, placenta has some problems and uterus shape is different, and they can be reasons because we have no clue about earlier sonographies regarding this.
Because when she was at home on the generally the ultrasonography is also done at only at around 20 weeks to just see that the baby is okay and all. So the good reasoning, Dr. Taru. So we will come back to you later on, and your good thought process. So first, let us finish with the second question. What instruction, now you are going to manage the case, and it is diagnosed and she is in labor and you are there. So what instruction would you like to give to your resident for managing this case? Dr. Achla?
Yes, ma'am. Yes, ma'am. Thank you, ma'am. Thank you for giving me this opportunity, ma'am. As we are already seeing that she's a patient of retained placenta and she appears to be in shock. So we need to advise our PGs that kindly resuscitate the patient, start oxygen, give put wide bore IV lines, the orange or the white ones, and
what I want to ask about after just like all the general resuscitative measures taking into care of the ABC,
giving oxytocin
what
to the
special
patient,
obstetrical management instruction?
And the ma'am, we will ask them to give IV oxytocin, the 5 international units in 5 ml of NS to be started, and then to inform the OT team, the anesthesiologist, the blood bank to give the samples, to arrange the blood products, and to give IV antibiotics, because we straight away need to go for extraction of the placenta in the OT. So we need to give prophylaxis IV antibiotics. We'll ask them to give IV antibiotics and then shift the patient to OT immediately and yes, to take a very speedy history also, that whether there are any high-risk things for past spectrum to be there, like anomalies or previous uterine surgeries, history of DNCs and previous sections, myomectomies, so that we can triage the patient that yes, she could be and she must be a case of past spectrum.
Okay, what a special investigation you will do other than your clinical judgment for past? In this when the patient is serious?
Yes, ma'am. We have. You mean about the blood product? I mean the blood investigations?
No. About this placenta.
We can go for bedside ultrasound if available, ma'am, to see the adherence of the placenta to the underlying endomyometrium interface, and then we can plan further.
Okay, so first of all, we know because it is a die handle case, or the proper active management of the labor which is needed definitely was not there, and because they give out of the way, they give this oxytocin at any time, whatever doses they know, whatever facility they have. Sometimes they give mesopros, sometimes they give even the methargine and direct syntocinon they try to give. And so generally it is mismanaged third stage of labor, because she was already, she must have tried everything, and because there is always a delay in coming to this. And so the physiological management of the third stage of the delivery is it is a thing where all the gynecologists nowadays, we are trying our best, especially the FOGSI, to train even the community and all the skilled birth attendants. No. So the next,
Ma'am, I just want to.
Yes.
I just want to add one thing to it. Everything, whatever is said, is correct, but we have to. First of all, we have to counsel the attendants and tell them what is going to happen and what danger.
Abhi will come to that. Abhi will come to that. Not danger, because obviously when you take the patient to labor room, you do all the things, you take consent and you do counsel, and whatever the next, even if you are just start doing the this thing, taking into care all the complications and all the whatever things is required. So many times, even in my when I was a resident, I started just doing everything. I was just managing, and all of a sudden I recognized that this is going, this uncontrolled cord traction must have been given to by the dye, and there was a signs of uterine inversion also, that she was in shock. Yeah. So next slide is Abhinath. This will come back to the third question. So first of all, so let's start. Ask me the question only. How to further proceed? Suppose there is a, we will try for this simple cord control cord traction, MRP. So these are the two different things. And when will you go for MRP, or will you try for this thing as a simple control cord traction? Dr. Achila?
Yes, ma'am, I'm here.
Will you go for simple oxytocin, just giving oxytocin and seeing the uterus?
Ma'am, actually the patient has already come to us after 2 hours of delivery, and she is bleeding also.
But
and her
maybe you just need to do like when you give antibiotic and oxytocin, and when sometimes the moment you give fluids and all, the patient is
comes up
here, and the placenta comes out on, even if with a simple control cord traction also.
Yeah, maybe it is just entrapped because of closure of the os, and it is not adherent as such.
Yes, but
then
anyway,
we may give it a try.
Whatever we are doing, it should be like this, one by one. If we just single, if we do the control cord traction, then we should be prepared for MRP.
Yeah, so it's better it's done in OT itself, so that we can switch to MRP as soon as it is failed.
Yes, thank you. And how to further proceed for just removal of placenta? Dr. Swati Rathore is there, our
yes.
Very
Are
good
you able
professor.
to hear me?
Yes.
Sorry, my video is not on, but my audio, it is good here. Are you able to hear me, Dr. Bharti?
Yes, Dr. Swati.
Yes, ma'am, you are audible.
Thank you for this opportunity. I'm very happy to be in this team. So as the patient has been handled by the dye, and she has reached to us in a condition of almost a shock. So when she is stable, it is something different. But when she is in shock, definitely the management will be like she came to the emergency with pulse of 124 and the BP is very low. So we'll shift her to the theater. Here also, the same thing, ABCD, what we are following, the same thing we have to follow for the PPH, what we do follow, the here also we will follow. So first, shift to the patient to the theater, ask for the general anesthesia preferably. Second thing, examine the placenta, examine the patient, put her in the lithotomy position, start on the antibiotic. What we usually give, ampicillin 2 gram and metronidazole will give her, injectable. Then, once it is done, catheterize the patient, then if you are the operating person, how we are going to do. Put the patient in the semilithotomy with the right hand, with the long gloves, put your hand inside, separating the vulva, going into the vagina, then into the cervix, because already placenta is there, so os is open. Then go till with the right hand, with the help of the cord, you are going to go inside the uterus. So with the left hand, you are holding the cord with a traction, giving a traction, and the right hand you are going introducing till the fundus. Once you reach to the fundus, leave the cord.
Just a minute. The left, where will you keep the left hand?
On the abdomen.
No. So first thing, the right hand, that is the dominant hand, it will go into the cone-shaped manner into the uterus.
You
the
just
left
follow
hand
the cord.
is
Yes,
holding it is going holding the cord so that you have a guide with that. Once you reach to the placenta, leave the left hand, because now already cord work is over. Keep that left hand on the fundus, give a traction on the uterus. Okay, so it's not a massage what we are doing here. Give a contraction. Then with the right hand, take out whatever the placentale you have reached till the apex. Then with the slicing movement, you have to separate the placenta with the dorsum of the hand of the right hand. You are separating the placenta from the uterine cavity and the placentale in between that. Or what we can say in place of slicing, you can say in the flipping order, like when you flip your pages of the book, like that manner you have to take it out. Okay, the left hand it is on the fundus, and the right hand it is inside the uterus. Once the placenta is whole in your hand, grab the placenta, take out whole of the placenta, whatever the maximum, bring it down. At that stage, you tell the anesthetist to start the oxytocin. So remember that oxytocin you should not start in the beginning, because we don't want at that time. Once the placenta is grabbed, bring it down. Then after doing that, with the left hand, start doing the massage once the placenta is out. Then examine the placenta completely, whether it is complete or any succinate lobe is left, or if any other part of the placenta is left. Once it is done, started the oxytocin with the normal saline, 20 to 40 minutes also you can start. Once uterus is good, it is not bleeding, then start the methergine if you think that it is atonic. So you have explored the placenta, you have confirmed, yes, the whole of the placenta is out. After that, feel the cervix if any injury you have done it. So these are the steps what we'll do. So what I can say, it is what we follow, it is a ABCDE of manual removal of placenta. So first, general anesthesia. This is for the postgraduate, what I want to tell. Anesthesia is important. Second is, and the antibiotics. B is for the bladder. So evacuate the bladder and keep the Foley's catheter, because we wanted to monitor the output also. Then third one is C. C is in cone-shaped manner, your right hand or the dominant hand, it will go inside. With the left hand, give a contraction. Okay. Once this is done, with the dorsum of the hand of the right hand, separate the placenta from the uterine wall. E is the extraction of the placenta and exploration of the whole of the uterus. And ergometrin, after the oxytocin, start the ergometrin. So this is the ABCDE, what we follow for the manual removal of placenta.
Dr. Archana, here I am of a little different opinion. Am I audible?
Yeah,
if you please permit me. If you please permit me.
This is what I want to. This is what I want to listen. I will give chance to each and everybody. Just give an opinion. This question, all the questions are open to all. Please give your this opinion also, everybody.
It is just sharing of my opinion. Yes, doctor, she has beautifully narrated everything.
Yes.
But because we also are quite old people, and we have seen the era when no sonography, nothing was available, and we totally dependent only on our clinical judgment. So we belong to that era. So that is how we work. It is not that that is not that something is wrong. It is only a way of doing the things. Patient of such a condition comes, usually by the time she comes here, she has lost most of blood, or maybe you have to make a quick assessment whether she is still bleeding or not bleeding. If she is not bleeding, it seems either the placenta has separated. Many times what happens? Yes. You simply relax the patient, do the PV examination, placenta is lying in the vagina, or maybe just in the uterus, just pick it up and the thing is done. Antibiotics, of course, you are giving. If the placenta is still not separated and we really need to go for the MRP, only thing what my experience is that like everything is okay, bladder has been evacuated, everything is there, patient is in GA, proper antisepsis is there, proper gloving is there. After that, what I do, I put my hand inside the uterus, but I am not putting it like in a specific cone-shaped manner. In a simple way, I am a right-handed person. My right hand goes inside and tries to touch a corner of the placenta wherever it is. Usually when we are going, we come to the edge of the placenta, not in the center. At that moment, I tell my anesthetist to relax the uterus, right? Many times, because in a government hospitals, it is a halothane. We don't have nitrogen, NTG or something like fancy things. We have the simple halothane or something of the old timers. Yes, he gives a small short bolus, and by that time, from one edge, it is from my palmar side. From the edge, medial side, like I start separating from there. Means that is how I find it easy to do. It is from my palmar side, my dorsum is towards the like uterine wall. I have to make a plane between the uterus and the placenta, right? Because it is the palmar side that is more sensitive to the touch also. If I try to put my palm medial side near my small finger on the one edge of the placenta, and if the like plane, once it is there, it is not so very difficult. Second part is, once the placenta is separated, even before removing it, means that time uterus is going to bleed heavily, especially in this patient who is already in shock. That may really create problems. So at that moment, I tell them, yes, please, वो सिंटो चालू रखा है करके रखा होता है, बॉटल भर के रेजिडेंट रखता है, तो start the Cinto at a very high speed. You may be requiring even ergometrin, because patient is already in shock. At that time, her uterine muscles, they are also expected to be in the acidotic. So that also contributes to the atony. So we give all the possible uterotonics, and then we take out the hand. By that time, the other hand, which is lying on the fundus, that is doing the slow, gentle massage. Once the placenta is separated, other hand is doing the gentle massage. Uterotonics are started, and then we take out the placenta and believe that, okay, that is done. Means the patient is not bleeding, the plane is there, that means placenta is removed.
Yes,
unless
I have one thing to add.
difficult, not much.
Yes, Dr. Shalja. Yes.
When we have a ultrasound, bedside ultrasound, we can just differentiate between a trapped placenta and then adherent placenta, or the placenta which is just adherent. It's not the accreta type, just adherent placenta. So if it is just a trapped placenta, we can just give a nitroglycerin spray or nasal spray, or a shot of nitroglycerin, and then that itself relaxes the cervix, with which we can just remove it.
Yes, exactly that point I wanted to just say, because once you are trying, then sometimes the resistance is felt right at the time of entering your hand when the os is tightly closed, and that is the time you need to get some relaxation, and this oxytocin should be going on, and the left hand should be like more towards the, just like your right hand is inside. I think like Bharti also, I want to ask Bharti also to give some inputs, because it should be a very gentle separation from edge to edge, with the right hand and the finger going like this, and the upper hand supporting the finger, because there's we need to have certain this to be done by experienced and skilled person, because all that we don't want any more complication in the shock patient. Dr. Bharti, please, your opinion here.
Yes, the discussion is going in the right way only. So here what importance is that whenever a patient is coming to us, the first diagnosis of whether it is a retained or whether it is a adherent placenta, the first important sign to look for is clinically whether there is any sign of placental separation. Now this patient has not delivered in front of us, so that straightening of cord we cannot judge, that gushing of blood we cannot judge. Yes,
But per abdomen, that uterine contour of changing from that discoid to globular and that fundal prominence definitely tells you that this is a well contracted uterus probably, and the placenta is definitely like to be separated, or it is separated. Another important clinical examination, when you put a finger, if you through the cervix, if you feel that placental separation margins are well felt, so this is the patient where an attempt of controlled cord traction and followed by MRP, if it is not being coming out through CCT, can be given. So these are the clinical indications where you judge the patient by going through clinically and then assess clinically, and the need of ultrasound for routine, just mentioning that this patient had an adherent placenta or a kind of placenta preta spectrum.
Yes, yes. And because, you know, yeah, very rightly, because in the adherent placenta, if you give upward this at the right, at the this side, just push to the uterus, if it is almost separated placenta, the cord does not
move. Yes. So these are very clinical signs which we need to
this
teach
is
our
something
residents
very
to
more
follow.
if we like in any case, if we use more of our clinical sense, and then it is always
Which we call as true lengthening of the cord, right, ma'am?
that is at the time of a delivery, because
exactly
later on also because the
Definitely
patient
looking
is,
at uterine contour will guide you definitely that stand up, you contracted, round, globular. So it means,
and I'm putting that hand, if the cleavage plane is there, and if it is not adherent, it goes very nicely on its
very
own.
nicely. Yes, very both around, just like it is this moment only, but with the swift moment it just comes out. And then we are very much sure, and even if single small resistance is felt, then don't try to do too much of this extraction or removal, because later on there may be many chances, and half separated bleeds more, and it may cause more complications. So next question goes to what life-threatening
Just a minute, Dr. Archana. Just one more minute I will take. Very simple thing, very common sense thing. You must also be following the same. Please ask your residents, not very junior person should not touch it. But what happens?
That I already said. Yeah,
that will further add on to your shock management.
That I was already said.
More experienced person.
That I've already said, that in this type of cases should be
that
handled.
time you have to be little strict there.
Under care. Yes. We should teach the PGs, but we should be there, and I think majority of the cases are handled by experienced senior persons. So the next question goes to what life-threatening complication are we expecting in this patient, and what post-procedure instructions you will like to write, Dr. Anjali Kanare.
Madam, as the discussion is going on in right direction, the patient is in shock, so we should anticipate all the complications which can happen because of shock, right from decreased urine output, multiple blood transfusions, and the patient is in general anesthesia, so we need to look into that aspect also. One needs to be sure that if we are able to go ahead and complete the procedure, then it is fine. We should not keep on trying and then make things worse. So when we are doing MRP, or when we are trying to do MRP, we need to be aware that rest of the procedure are getting lined up if as and when required to manage the PPH. That is very important, because we just don't know. It could be, as rightly said, though she is a primary gravida, a 20-year-old, but nowadays there is a tendency of patients to hide history also many times. So one needs to be aware that everything else is ready in the theater, and we should attempt only once to remove the placenta if it is possible. The second thing is, definitely there are chances of infection. We all have mentioned that antibiotic coverage is must. Then there are chances of inversion. So post-procedure also, we need to keep, or we need to ask our PGs or whoever is looking after to keep a watch on the abdomen, to feel the abdomen, to look for the fundus, to keep a check on abdominal circumference and see that things are in right direction as we want it to be. Definitely after MRP, we need to be sure that the placenta is removed completely. And if there is any chance of having bits and pieces of placenta which are left inside, we need to make sure that we take care of them. So these are the common complications which can happen. And many times this can cause lifelong morbidity with the patient, which we need to be sure about.
Yes. Even just a clinical tip I just want to say. Then when we I did many MRPs when I was in medical college, and but that is so many years back. But the only tip was that whenever with the right hand, it should be as quick as possible, and I never used to remove my hand from inside, and then when all thing was clear according to me, that placenta is separated, and then with the hand sometimes just simply again no, because we don't want to do any curettage or any suction or anything or any more manipulation. So just simple checking, and just don't keep out and inside again and again, because that leads to infection. And soon after that, all those aseptic precautions, putting the betadine and all the simple things, and just taking care that uterus is well contracted, and the left hand used to massage especially. And generally there's no need to do regular ultrasound also after MRP once there's no bleeding and this thing. So the well done panelists for this question number 1. I think Dr. Bharti, I've got some emergency. You please take just carry on with this all this next case and even this key messages in this, please.
Okay.
All the panelists, I will be back after 5 minutes, and then please carry on. Dr. Bharti.
Thank you, ma'am. Thank you. So definitely the message by this case is that most of the time we encounter such cases, they are the patients who have a retained or incarcerated placenta. And if we feel that everything, the uterus, the placenta is separated, first we can go step by step by CCT and then MRI, MRP and the general anesthesia. Antibiotics are required or recommended only for the MRP. If we are doing it by CCT, then no antibiotics as such. And for MRP, what are the guidelines for antibiotics are the same as prophylaxis done in cases of cesarean. So we use cephalosporins, or allergic, you can use the clindamycin. So the prophylaxis as given for the cesarean to prevent only endometritis. So those antibiotics only for prophylaxis has to be given. Institutional deliveries, because we know that in this patient, 3rd stage of active management was missing, probably because she was a conducted delivery by dying. So no CCT was there, and we presume that oxytocin must not have been given. So in these cases, there are chances that only in 80% of cases the placenta is delivered, and 20% of the cases it takes long time, or sometimes you have to do some kind of assisted procedure. So what we conclude, so this was a case where a simple retained placenta was there. Now moving to another kind of scenario which we just managed 1 month back. This was a 19-year-old lady who had a history of infertility. This is very important. She has delivered at Ludhiana hospital, and she was referred to us with the retained placenta. So removal was done in that Ludhiana hospital 2 times. Once they did it in just a simple labor room by a senior consultant, and after that they could not do it, and then they take the patient to the OT table, and at that time by giving the anesthesia they tried to do again the manual removal, but they could not do it. Then they had referred the patient to the PGI. On receiving, the patient had a vitals of 100 per minute pulse rate with blood pressure normal range, and what we could see is that uterus was 28 weeks size, but on clinical perception we found that this uterus is deviated more to the right side. So this was a little abnormal finding for us, which somehow made us to think little different. And so we did ultrasound, because here the indication of doing the ultrasound was there because 2 times attempt of placenta removal was already done outside, and it was done in the OT, and it was not coming out. So definitely we were dealing with a case which was little complicated and different. So we wanted to look into the placenta and kind of anomaly if you are thinking of. So we did an ultrasound, and that ultrasound showed, although that there is a separation of placenta with the myometrium at good places, but there were some few points where we could not see any intervening myometrium between that placental attachment and as well as the placenta. So I would like further to know from Dr. Mudita, ma'am, what do you think? What kind of scenario we are dealing with this case? Do we have Dr. Mudita with us?
No, Dr. Mudita could not join. Dr. Sudesh also. Yeah.
She has not joined. So I would request Dr. Sudesh if she can take this question on.
Sudesh also.
This is a real
Dr.
good
Shailaja.
question.
Dr. Shailaja.
Shall I take the question?
Yes, please, ma'am, most welcome.
Yeah, from this history, it is more in favor of the placenta accreta spectrum. And so we can go for further investigations, like you can confirm it with an ultrasound and a Doppler. And in the ultrasound, we can, if it is, there'll be the absence of the clear zone, and there'll be thinning of the myometrium, and the placental lacunae will be seen, vascular lacunae, and even the white line will be distorted. And if you put on the Doppler, there will be increased vascularity at the junction, and there will be bridging vessels, and the turbulence is seen in the lacunae within the placenta. And to know the extent of the invasion and the depth of invasion and the extent, the lateral extension of the invasion, you can go for an MRI. MRI also, this gives, it's more specific, and it will tell you the more details.
Okay. So, ma'am, only the different thing.
Madam, can I just add one more thing?
Yes, please.
Looking into the history, we need to rule out any uterine malformation also, because she has had 2 previous attempts and when placenta was not been removed. So rightly said by Madam, MRI will put all these aspects into light and make management a bit easy.
Yes. So well said, ma'am, but the only thing which I feel that will go a little against placenta accreta spectrum in this patient is, first, she is a primary patient, and the second thing is that we see that yes, it can be a focal adherent placenta or focal accreta, but when we did the ultrasound, so we could see that at most of the good areas we were able to see an intervening layer between the placental separation and myometrium. It was the first few points where we were feeling that we are not able to see that myometrium. Yes, we have to think in form of focal accreta, but another important thing, if we do see from the clinical examination, is that this uterus is not like a centrally placed uterus. It is a uterus which is more deviated to right side. It was such an abnormal finding. You just place your hand in the sense that you are not seeing anything, but on one side you are seeing that uterus is like deviated to one side. So that made us to think in a different way also. Yes, focal accreta, we were thinking.
Dr. Bharti, yes, we have finished 40 minutes, and yeah, maybe 5
I think
minutes.
we should just go in a rapid manner now, ma'am. Hello.
Yeah, sure. Yeah, please.
Yeah. So, so the ultrasound definitely can distinguish. So this was a case, basically, ma'am, we were dealing with the uterine abnormality, and yes, we did MRI in this patient because we thought from 2 attempts failed, and ultimately what was it was a kind of septum where we could not see any intervening membrane. So we did we tried to do the extraction manually. We could not insinuate our fingers, so it was done by the instrumental extraction, and definitely we were able to take out all the placenta. So this is a case where uterine anomalies, because it is implantation into the one cornua, and then definitely the uterus is deviated to the one side. In such cases we do see, because in septum there is a kind of poor implantation and difficult placentation, and definitely a difficult removal of the placenta. So other thing, then take home messages for this case is that always think. Yes, ma'am. Now we
Very
should
interesting case, Dr. Bharti.
Thank you, ma'am. Thank you. So
Can I take
the third case, ma'am, or should I stop here? Because this is an important case. If you give us,
you can take it, but you need to wind up in 3-4 minutes.
Okay. So this was a case we received 15 days back from Patiala Medical College. They had a placenta accreta antenatally diagnosed patient. They did cesarean. Actually, they did a classical cesarean of this patient, and after that, they just closed the uterus and leave the placenta in toto, and they have sent the patient on day 8 post-operatively to us for the further management. So I just wanted to know from Dr. Taru Bansal, how would you further go about this case? This is a case of proven accreta from outside, and she's dead post-op with stable vitals, no evidence of infection. So ma'am, what is your take on management options for this case, Dr. Taru?
See, we have 2 options. Number one, patient is not bleeding, stable. Number 2, patient is bleeding. So in the both cases, our management style will change. If the patient is not bleeding, and we know that there is placenta accreta, and that we can leave as such, but we have to follow the patient very regularly, uske vitals, and we have to cover it with antibiotics and regular checkup by beta HCG we can do by regular screening sonographies, and we can keep the patient hospitalized for 3-4 days and just watch the patient vitals and see. If the patient is okay, then we can leave like this only, because slowly patient phagocyte.
Yeah, you are absolutely right, Dr. Saru. Even we have left so many patients. It happens once in a while, not so many, but once in a while it happened, and used to leave it. And after 6 months or later on, we follow. Later on, the patient deliver also. They have pregnancies, they deliver.
Dr.
But
Bharti,
now,
I would request you to quickly go through the case and give the final.
In case patient is bleeding, we definitely
I'm
we have
here.
to.
I'm here.
Yes, ma'am. Would you have proceeded differently if you were a primary?
Yes, ma'am. As you have said that this case was antenatally diagnosed, and if it was diagnosed in early pregnancy, we could go for counseling for the termination of the
Ma'am, termination
pregnancy. If not very early diagnosed, we can go. We will give steroids to the patient, and we will plan her LSCS at 34 weeks, a bit earlier. And after planning the LSCS, we will choose a place where we have established infrastructure with a very good OT, with a very good blood bank, and a very efficient and experienced team who can deal with placenta accreta spectrum, including a hematologist, a general surgeon who is very efficient in pelvic surgery. We will need
maybe
perinatologist. We will
Ma'am,
need
Dr. Achla, we can take patient to the term also with all these things in hand.
The guidelines say that we should.
Yeah, Dr. Joshi, I would request you to give the final, because PIS is such a vast thing.
Yes, I do understand. So I'm just minding up, because the guidelines for placenta accreta is not before 36 weeks, but say at 36 to 37 weeks performing everything. So the primary management options could have been for this case to perform hysterectomy at the center where it is being primarily done for the accreta. She has already 3 issues. To perform delayed hysterectomy, yes, they have done it because they have a good experience and it decreases the blood loss. To leave the placenta for autolysis, yes, most of the panelists do agree. Now she is not bleeding. And conservative management or partial exclusion of uteroplacental event in case where patient feels her uterus need to be cared for. So with this, I think I need to close the session because we are already running behind the time. Although we can.
Thank you so much.
Just a word about the intervention radiologist. Does anybody has the experience?
Yes.
Embolization of
uterine artery embolization we also have done of this type of patients where the patients are referred to our hospital with a placenta in situ and the patient is stable. You can go ahead with the uterine artery embolization. The autolysis and the expulsion of placenta is very faster. Or second thing, you can give the methotrexate also if the patient is stable.
The role of methotrexate is now being
very controversial. It is not a
controversial.
Yes.
The new FIGO guidelines say no role for methotrexate. So that is one thing which we have to not to give the message.
Madam, as was mentioned earlier, 80% will resolve themselves and can have future pregnancies also.
Yes, it takes 13.2 weeks for the total rhythm. It can vary from 4 to 60 weeks, but mean is 13.2 weeks. Yeah.
And
there is a recurrence of
recurrence. Yes, Shailja.
There will be a risk of recurrence of the accreta in such patients. If there is an accreta in the
And one important message is we can't try all this in peripheral centers or even tertiary centers where we cannot deal with the delayed or secondary hysterectomy. Much more, advanced centers only we can try this, wait for resolution and all, because she can land up with hemorrhage at any point of time. With that, I'm sorry if I've hurried the last part, but we are running really, really late. Thank you, Archana.
Thank you so much. Thank you so much. Thank you, Archana madam. Thank you,
wonderful panel with 3 very interesting cases, and I'm so happy with all the panelists, teachers experienced from institutes with a lot of experience. Thank you, each one of you. Without further delay, we would go on to the another interesting section of our quest series, which thanks to
just 1 minute, Kiran.
Archana ma'am, please.
I'm very sorry that I went, and just thank you very much. And one homework for all the panelists. Just think for leaving placenta at the time of cesarean and just let me know. Just write to me. Not here, no discussion here, only on WhatsApp. So many, I have heard so many people leaving, closing this abdomen and leaving the placenta. So one line for that. What is your opinion, house opinion? And Dr. Kiranmai, thank you. Carry on.
Thank you, Archana ma'am. Thank you for the wonderful panel, really. The 3 cases and very apt, and the discussion went on in such a beautiful way. Thank you so much. So now moving on to our next interesting segment. I was telling that this is thanks to Dr. Krishna Kumari madam, who thought we should have a scientific research article discussed in along with our academic CMEs. So in the first CME, we discussed the gut microbiome, wherein Dr. Ruchika and Dr. Geeta Balsarkar madam had discussed an article. Now we have this article review, tranexamic acid in PPH. For this, we have Dr. Jaya Chawla, who is an associate professor. Can I have Dr. Jaya's CV, please? Yeah, first let me introduce Ashok Kumar sir. Please go back. Ashok Kumar sir needs no introduction. He is presently the secretary of ICOG now, and he has put its CV very short, but he has hundreds and hundreds of publications, and really proud to know you, sir. He's director, professor, and head department of OB-GYN, Atal Bihari Vajpayee Institute of Medical Sciences and Ram Manohar Lohia Hospital, New Delhi. And next, can I have Dr. Jaya? Sir would be moderating this, discussing this article review along with Dr. Jaya Chawla, who is associate professor, Department of OB-GYN, ABV IMS and Dr. RML Hospital. She's a fellow maternal fetal medicine, fellow of Indian College of Maternal and Child Health, and a lot of things. She's a postgraduate medical teacher and reviewer of Biotechnology Industry Research Assistance Council, reviewer of Journal of Fetal Medicine and Jogi, and multiple publications and chapters. Welcome you, Dr. Jaya. Over to you and Ashok, sir.
Good evening to Dr. Kiranmai, Dr. Krishna Kumari for this initiative to start this type of program from the FOGSI platform. And Dr. Mitra Saxena is always there to have this program in line and in practical for everyone. And we thank President our FOGSI, Dr. Shanta Kumari Madam also, who is the main force behind all of us, I think. And we are missing you, Madam, here today. With all these words, we thank the organizers also to give us this opportunity to be a part of this initiative and to present the journal review from Atal Bihari Vajpayee Institute of Medical Sciences and Dr. Ram Manohar Lohia Hospital, New Delhi. And we hope that the presentation by our institute will fulfill your all the need for a journal review and the new information on the role of tranexamic acid in PPH. So I have Dr. Jaya Chawla, who is a faculty, a young faculty with lot of energy and lot of, I think she's full of energy and a very good orator. And she has done medicine. She will be presenting the review on tranexamic acid in PPH. We have tried in short to see how the tranexamic acid has come up to this today's stage, how it started, and now it has been used in various guidelines and recommended by various guidelines and various international bodies to be used as a prophylactic as well as therapeutic agent for PPH. So over to Dr. Jaya Chawla, and I think at the end we will have some fruitful discussion also.
Thank you, sir. Very good evening, everybody. Thank you all for placing me here among this stellar constellation of experts, Kiranmai ma'am. And sir, can I share my screen, please?
Yes.
Thank you. So on behalf of the Department of Obstetrics and Gynecology at the Atal Bihari Vajpayee Institute of Medical Sciences, I shall be taking you through a literature review of tranexamic acid in postpartum hemorrhage. A brief idea about the pharmacology for the postgraduate students. We all know that tranexamic acid is a competitive inhibitor of plasminogen activation and therefore leads to competitive inhibition of the production of plasmin. The role of plasmin in circulation is to degrade fibrin into its fibrin degradation products. So I would like to emphasize here in the first place that tranexamic acid stabilizes the clots that have already been formed into the circulation. It does not lead to formation of new clots. To begin with, I shall be taking you through tranexamic acid for the treatment of postpartum hemorrhage, be it vaginal delivery or cesarean section. So we shall be dealing with the therapeutic aspect of tranexamic acid here. It all began with the CRASH-2 trial in the first place in 2013. And that trial evaluated the role of tranexamic acid in adult bleeding patients. Continuing further, the women's trial evaluated the role of tranexamic acid in obstetric settings. It was a randomized double-blind placebo-controlled trial spread over 193 countries in 193 hospitals in 21 countries. Included women who were already experiencing postpartum hemorrhage, be it in vaginal birth or in cesarean section. A Cochrane review that we'll be discussing subsequently has assessed this trial to have a low risk of bias and has been shown to have moderate to high quality of evidence. They randomized women to receive 1 gram of intravenous tranexamic acid or placebo in the setting of postpartum hemorrhage. And if the bleeding continued for 30 minutes or more later, or if there was a repeat bout of hemorrhage within the stipulated period of 24 hours, the same drug or placebo was repeated. The authors concluded that tranexamic acid reduces death due to bleeding in women with postpartum hemorrhage with no major adverse effects, but it should be given as soon as is possible after the onset of bleeding. Women's trial had over 20,000 participants in it, and that is why it has a bigger learning curve for all of us. The first learning curve is that tranexamic acid should be given at the onset of hemorrhage itself, especially within the first 3 hours from the timing of birth. The second learning curve is that tranexamic acid has benefits to offer irrespective of the mode of birth, whether it is a vaginal birth or a cesarean section. The third learning curve is that irrespective of the cause of hemorrhage, whether it is atony or other causes, tranexamic acid can come to our rescue. So taking cues from the women's trial, the WHO announced its guidelines in 2017. To make it more crisp, according to the WHO 2017 guidelines, all cases of postpartum hemorrhage, regardless of cause, should be offered tranexamic acid within 3 hours of birth, the reference point of which is the time of birth of the baby. It should be given as a slow intravenous infusion over 10 minutes because a bolus can lead to transient hypotension potentially. A crystal clear idea of 1 gram per 10 ml given over 10 minutes as 1 ml per minute should be transfused. And this can be repeated after 30 minutes or again within 24 hours if bleeding continues or ensues. Another set of learning from WHO 2017 guidelines is that this can be mixed with electrolyte solutions, carbohydrate or amino acid solutions, dextran solutions, and can be given through the same cannula as uterotonics, a very practical point. The second idea is that it should not be mixed with blood for transfusion, should not be given alongside penicillin or mannitol in the same syringe. Now, the difference between 2012 and 2017 recommendations from the World Health Organization merit a discussion. In 2012, after the CRASH-2 trial, the WHO had said that the tranexamic acid should be administered once oxytocics have failed to curb the bleeding. And this idea came to a change in 2017 with the update saying that it should be given in all cases of PPH regardless of the cause. The timing in 2012 was once Uterotonics had failed to curb the bleeding, and here it was crystallized to within 3 hours or as soon as possible after the onset of hemorrhage. The dosing here was a little vague as 1 gram intravenous slowly, and now we are very clear that it has to be 1 gram in 10 ml given over 10 minutes. So this is exactly what women's trial did to these recommendations. Then came the Cochrane review, 2018. This had 3 studies, but the major chunk of its evidence came from the women's trial. And the idea was to determine the efficacy and safety of antifibrinolytic agents to treat primary postpartum hemorrhage. But only tranexamic acid was studied since the other agents did not have any trials to offer. The participants were women with more than 24 weeks of gestation at the time of giving birth, and they were all diagnosed with postpartum hemorrhage. So remember, we are talking at this moment about treatment of postpartum hemorrhage, irrespective of the mode of birth or other aspects of third stage management. Since the major chunk of the Cochrane review was women's trial, it echoed the same sentiment in terms of less than 3 hours a window to administer the drug, irrespective of the mode of birth. Additionally, maternal mortality due to bleeding is reduced substantially when you give tranexamic acid. Tranexamic acid did not reduce the risk of serious maternal morbidity, did not reduce the risk of hysterectomy, did not reduce the quantum of blood products that you need to transfuse to stabilize the patient, did not lead to reduced requirement of uterotonics. So it is not a substitute for uterotonics that we administer for atonic postpartum hemorrhage. 2 other findings of note are that laparotomy to control bleeding is reduced significantly, albeit at a cost of an increase in brace sutures. So all the advantages that we can sum up from all these reviews until this point of time are that tranexamic acid is not expensive. It is easy to administer, usually available in healthcare settings owing to its use in other departments such as trauma and surgery. It has a good shelf life of 3 years, so can be held in store and can be stored at room temperatures of 15 to 30 degrees Celsius, which is a major boon to a country like ours. The disadvantages are that it is contraindicated in settings where the patients are hypersensitive to the drug, in cases of severe renal impairment, which can be encountered in cases which have chronic kidney disease or which have renal impairment of a severe nature secondary to over-diabetes in obstetric settings, or in cases of hypertensive disorders of pregnancy presenting with renal impairment. Also, it is contraindicated in history of convulsions and in settings where patients have active intravascular clotting. The American College guidelines, I would like to share a brief snippet here that the bundle says that stage 1 is where blood loss is to the tune of more than 500 ml for vaginal birth or more than 1000 ml for cesarean birth, but the patient is stable in terms of the vital signs as of now. Stage 2 is ongoing hemorrhage where more than 2 uterotonics have been placed into action and the woman continues to have normal vital signs and lab values. Stage 3, where ongoing hemorrhage is more than 1.5 liters, the patient has coagulopathy ensued or has now developed abnormalities in vital signs, laboratory maneuvers, and oliguria. And stage 4, the stage of cardiovascular collapse. So with this background, I would like to initiate that the American College of Obstetrics and Gynecology initiates the role of tranexamic acid at stage 2. Stage 1 is where they administer uterotonics. So stage 2, they are trying to suggest that tranexamic acid has a role besides the stage 1 medications. That means it is used as an adjunct. Also in stage 3, where they offer tranexamic acid, it is in conjunction with all the uterotonics that are administered as a norm in all patients of postpartum hemorrhage. So American College treats tranexamic acid as a drug which is adjunct to the management of postpartum hemorrhage. Whereas the World Health Organization suggests that it should be given to all women experiencing postpartum hemorrhage as soon as is possible within the 3-hour window. The FIGO in its statement in 2021 suggests that the early use of tranexamic acid within 3 hours of birth in addition to standard care in women clinically diagnosed with postpartum hemorrhage, irrespective of the route of delivery, as a component of the first response bundle when the bleeding is thought to be due partly or solely to trauma. So this is where we finish with the role of tranexamic acid in treating postpartum hemorrhage. And now in the coming section, we discuss its role in prevention of postpartum hemorrhage. Here we shall be discussing the studies that involve cesarean sections first. So there is a meta-analysis involving 18 randomized controlled trials with over 1,700 individuals in both the tranexamic acid as well as the control arm. And here tranexamic acid has been given prior to cesarean birth to see whether it reduces blood loss. And the evidence suggests that there is a favorable impact on postpartum hemorrhage, favorable effect on the need for blood transfusion, and especially on postpartum blood loss. There's a 60% reduction in mild to moderate PPH, 68% reduction in severe PPH, and 70% reduction in the need for blood transfusion based on the conclusions of this meta-analysis. Coming to the Cochrane Review 2015, which has included 12 trials with over 3,000 women. 9 of these trials are on elective cesarean and 3 on vaginal birth. Remember, these are women with a low risk of postpartum hemorrhage, and we are talking about prevention of PPH using tranexamic acid. The ideas that follow include that effect of tranexamic acid on reducing blood loss to less than 500 ml is more pronounced in vaginal births, less than 1000 ml in cesarean births, which is technically the definition for these two processes. The mean blood loss, need for additional interventions and blood transfusions is decreased significantly in both vaginal birth as well as cesarean sections, albeit at a cost of increase in minor side effects such as nausea and vomiting. Despite such extensive evidence, we still do not have conclusive evidence on the risk of thromboembolic events, whether tranexamic acid reduces mortality if used as a prophylaxis, or what is the nature of its outcome in high-risk women. Coming to tranexamic acid for prevention of PPH in vaginal births. And we discussed the famous French TRAP trial, the tranexamic acid for prevention of blood loss after vaginal birth trial. The significant idea here is that clinically significant PPH as perceived by the provider is reduced significantly. Additional uterotonics required to curb bleeding are reduced significantly. However, the primary outcome of reduction in postpartum hemorrhage does not get reduced to significant levels. And the conclusion is that among women with vaginal birth who receive prophylactic oxytocin, as we normally offer in all settings, tranexamic acid did not result in a rate of PPH that was significantly lower when compared to placebo. Another table from the same study suggests that vaginal births, operative births stand to have maximum benefit when given tranexamic acid vis-a-vis those where operative intervention was not utilized, and those where episiotomy was given stand to have more benefit as compared to those where it was not given. So the idea here is that results for tranexamic acid are superior when trauma is involved in vaginal birth. Last but not the least, we discuss a meta-analysis, which is the idea of which is to evaluate efficacy of tranexamic acid administration in preventing postpartum hemorrhage in vaginal births. And we see that total blood loss is reduced. Post-delivery blood loss specifically is reduced significantly. Yes, albeit at an increase of nausea and vomiting, which are minor side effects. So what do we conclude from this entire literature review of treatment as well as prophylaxis of postpartum hemorrhage using tranexamic acid in obstetric settings? We conclude that there is high-level evidence that tranexamic acid is useful for the treatment of postpartum hemorrhage when given less than 3 hours after birth. It is best used with oxytocin, but prior to initiating blood products. Insofar as the prophylactic use of tranexamic acid in cesarean births is concerned, the evidence supports this use. However, in cases of vaginal birth, robust evidence is yet to drop in. Thank you all for patient listening. it was wonderful having you with us here.
Thank you, Dr. Jaya Chawla, for this presentation. And I do hope that almost all the concepts are clear, and whatever evidences are available in the literature, we have tried to mention and make you familiar with all the conclusion about those trials and the studies. One thing I may add here, see, tranexamic acid should be very carefully given in the women who are at risk of thromboembolic. We know how this tranexamic acid will behave in these patients. So the women who are on anticoagulant earlier, or some women who are heart disease or having myocardial ischemia, they are on drugs. So in those women, we should be rather careful in using because they are at very high risk of thromboembolic phenomena. So therefore, this is the only caution I think we have to be worried about, beside, as Dr. Chawla has mentioned, about renal and all these things. But this is a very important thing, and we are dealing the pregnant patient with a lot of heart disease and all these things. So one has to be careful about that. I think with the permission of the organizer, now we can open it for discussion if there are any comments from anybody, although it is becoming too late now, but still, if there are some comments. Thank you, Dr. Kiranmai and Dr. Krishna Kumari Madam, for inviting us and giving us this opportunity. Very excellent platform, and thank you very much.
Thank you very much, Dr. Ashok. It was a pleasure listening to Dr. Jaya and your expert comments. It is a very well guided review. And that's what we wanted to bring into the limelight, that whether tranexamic acid is like, now once the gates have opened for the usage of tranexamic acid, we just thought that it should be properly, when we are starting to use it, we should use it in a proper way. And having an article review and having an idea about what is right and what is wrong is the best way to go about it. And I think Dr. Jaya has brought out those points wonderfully well, with added comments by you on when it is contraindicated. So I hope the message has gone deeply and thoroughly into everybody, all the listeners, of when not to use, because tranexamic acid is used left and right. But most importantly, when not to use is what we wanted to, so that there won't be any after effects of misuse of Trenexa. Thank you both so much. And we apologize on behalf of Kiran and me and the whole team of this particular program. We are really apologize for the late time. The time has gone really, really long, but it was such a wonderful deliberation that we couldn't cut short anything or anywhere and intervene anywhere. Thank you all so much. And we also thank all the faculty, as well as our team, which has given us audio-visual support. Most importantly, our president, Dr. Shanta Kumari, and the whole FOGSI team. And of course, most importantly, the delegates who sat through all these deliberations and have heard of all these interesting topics.
We have approximately 500 delegates who logged.
Actually, I'm in Vizag. I came to Vizag as an examiner. I was talking to one or two of my professors just now from here, and I just realized that all of them are listening. Oh, they said, how come we just saw you, and how come you're in Vizag? I said, I'm doing it from Vizag. It was such a pleasure. Thank you so much. And I think, Kiran, any closing notes?
Actually, today's...
Or anybody, any queries in this thing?
Because anyway, we have been late, so anything... Yeah. Thank you so much.
All our experts are available all the time. So just post them and they'll answer you.
Yeah.
As any
I
query.
think we'll keep the group for one day so that we get the YouTube link, and even Belats have promised to post the videos, hopefully. So today was really, really a learning experience, and all the teachers, experts, and seniors from FOGSI. As Madam said, thanks to Shanta Madam, Madhuri Madam, the whole team of FOGSI, and the vice presidents who are always there with us in every sense of the word. Archana Verma Madam and Kavita Madam, she could not be here today. Thank you so much, ma'am. And our guests of honor, Dr. Prakash Trivedi sir and Dr. Sanjay Gupta sir, despite being their very, very busy schedules. And today we had Atul sir and Ashok sir, all of them who were in the midst of their emergency surgeries, but still they made it to the webinar to be part of this. And all the speakers, we had even seniors for the 10 minutes fast track, but I'm really obliged and happy that they all obliged us to complete it in 10 minutes and giving us the essence of the topic. Thank you, Mitra Madam, Dr. Preeti, and Dr. Jayam Madam, including Dr. Jayam Madam, who took it in 10 minutes, Dr. Belat Sir, Dr. Niranjan Chavan, Krishna Madam, yourself, and Dr. Hema Madam. And those three talks were thoroughly, we had enjoyed Dr. Aturi Sir and Dr. PPH Care Bundles from Dr. Poonam. And the panel was excellent, very specific to the topic given, retained placenta, neither more nor less. And all the panelists we had were very experienced professors and teachers and seniors. Dr. Taru Chaya, Dr. Archana Verma Madam and Dr. Bharti Joshi and Dr. Taru Chaya, Dr. Achla Sahai Sharma, Dr. Swati Rathod, Dr. Anjali, then Dr. Sudesh Agarwal Ma'am. It was a pleasure to listen to you. And Dr. Shailaja from Vizag. And the last segment, but very interesting. We are looking forward to this segment a lot more in the future quest series also. Ashok Sir and Dr. Jaya Chawla. Ashok, I just gave it to Ashok Sir and then he did the rest of the thing, picking up the speaker reviewer for this articles, and it was wonderfully done. Thank you so much, and thank Venkat, Tirupati, and the meaty teams, and Dr. Nivedita who presented in place of.
एक और मुझे भी बोलना है, एक sentence.
Ma'am Aruna ko bhi
It's
thanks.
one of the most hit program, and the team is only winner, supposed to be the winner if the last player makes century. So Dr. Ashok and Dr. Jaya Chawla has done a wonderful job, and so
Thank you.
This K&K team, the rocking team, we want more and more program like that. And Dr. Taru Chaya, Dr. Jaya Chawla, आपका तो बस अब नंबर चाहिए और.
Yes, madam.
Anytime. Dr. Ashok is there for you to get things done.
Sir has all the numbers, ma'am. Thank you so much.
Part of your team only, no, for Dr. Archana, Dr. Ashok.
Madam,
number चाहिए. एक होता
madam, we are all part of your team.
That's true.
Autograph चाहिए. Dr. Ashok, Dr. Jaya, well, wonderful. I liked it. Dr. Krishna and Dr. Kiran. I gave this name K&K. है ना, KK तो आप ना समझ ही रहे हो ना.
Oh, okay. K&K. Okay.
We are a decade and more old, madam. From 2010.
Good.
So always.
K&K trial. वो तो होता ना, इतने सारे champion trial, women trial, K&K trial. अभी जिंदगी. Bye. Thank you.
Bye.